upper limit of norm. Who is going to answer the question? Is it A or is it B or is it C or is it D or is it E? Hypercalcemia. Hypercalcemia can be a non-specific finding, doctor. You can find many things in many things. Serum ALP also is a non-specific marker. You can find it increased in many things. Serum PSA has nothing to do with your Paget's. All right, it has nothing to do with your Paget's. The answer is B. Okay. Multinucleated osteoclast and bone biopsy. Why I will tell you. First thing here, I will tell. Mixed sclerotic and lytic lesions on X-ray, yes, it can signify Paget. But with this particular finding alone, you cannot come to a conclusion because many malignancy also produces similar changes. But though it has a good sensitivity of Paget, but if you find a multinucleated osteoclast on a bone biopsy, nothing is close to that other than Paget's. That is a very, very, very distinguished marker for Paget's disease. Okay. So the answer is multinucleated osteoclast on bone biopsy and not mixed sclerotic and lytic lesion. Next question. What they are asking, straight away some clinical features of insulinoma. But they are asking here, what would be the most useful investigation to establish a diagnosis of insulinoma? We have seen multiple questions. So I want one of you to answer what is the investigation you will do for insulinoma. I am not going to show you the options. Come on, quick. Any one of you. Without seeing any options. Okay. They're asking insulin hypoglycemia test, oral glucose tolerance test, measurement of HbA1c, simultaneous measurement of fasting blood glucose, insulin C-peptide, measurement of serum 3-hydroxybutyrate. Now, yes, the answer is E. We have seen multiple questions. We have seen multiple questions on this. Simultaneous measurement of fasting blood glucose, serum insulin, and C-peptide. When you do that, and then put the patient on 72 hours fast, then you will get to know the stuff. All right. The abdominal CT will reveal the finding. Then you can proceed with this. All right. Now, a patient comes to endocrine clinic for autosomal dominant diabetes with HNF1 alpha mutation. Which of the following cells most likely to be affected by the mutation? Oh, now you would have got it. HNF1 alpha. Which particular thing is close to this? Which particular entity is close to this mutation? Anybody? Which particular condition? HNF1 alpha. Yesterday we have seen, we have discussed same thing only. MRCP, if you just know the concepts, know the basics. Oh God, now Modi 1, 2, 3, so many answers. I told you to go and refer the table on Modi in my core concept lecture. So what cells will be affected? Yes, everyone will answer. Alpha, beta, hepatocyte, fat cell, delta cell. The answer is beta cells. Okay. Beta cells of the pancreas. This is back to MBBS level question. Okay. This is an MBBS level question. Now, 52-year-old businessman undergoes a routine medical examination as a part of his company's health program. He has no symptoms, but he is obese and his BMI is 31. His blood test performed in a fasting venous sample shows serum glucose concentration of 7.1 millimole. This is repeated by GP. Again, it's 7.1 millimole. So without seeing options, you're seeing somebody's serum glucose level. I think on a fasting sample, yes, on a fasting sample, constantly you are seeing 7.1. What will you infer from that? Will you judge that person as type 2 diabetes mellitus, or you will tell impaired fasting glucose or impaired glucose tolerance? What is your inference? Anybody? Okay. Is it normal? Impaired glucose tolerance. Diabetes mellitus, impaired fasting glucose, simple obesity. Definitely. The answer is diabetes mellitus. All right. The answer is diabetes mellitus. Okay. Serum glucose above 7, straightforward. You have to go for diabetes mellitus. All right. And now the classification of diabetes mellitus has been significantly changed in recent ADA. Earlier, we had some classification called insulin dependent and non-insulin dependent. Now it's not the truth, right? Once type 2 diabetes people, they cannot control the tank and they cannot live a healthy, active lifestyle. They will end up becoming dependent on insulin because how much pancreas can exert itself beyond a point, it will give up. All right. So they will also become. So that classification has been removed. Then recent classification came type 1 and type 2. That is also removed. Now a newer classification has come, which I have told you in the core concept lecture. You guys can see that. Okay. Next, 59-year-old taxi driver. Everything is important here. It's a taxi driver comes to the diabetes clinic for review. He has type 2 diabetes for the last 15 years. He has now developed diabetic nephropathy. His blood sugar control is suboptimal. He is currently taking linagliptin as monotherapy. BP is 155. Then BMI, see here, it's 35. HbA1c 82. Creatinine is high. eGFR is going absolutely down. So what you will do for this patient before going to the options, you are the clinicians, sitting in the clinic, and this guy is coming to you. Maybe you are the medical registrar in NHS. You are seeing this guy, a taxi driver, full-blown diabetic nephropathy, approaching for end-stage renal diseases, eGFR declining, creatinine is up, is having high BMI, is just taking linagliptin. Rationally, what other drug you think you will add? All of you can give your opinions. We have a lot of people here now. All you guys tell your opinion. There is nothing wrong. Give your opinion here. Please don't give like opinion here in the main exam. That is your MRCP part one. Okay, increase the dose and counsel for lifestyle and diet. Add SGLT2, GLP-1, empagliflozin. Good. What is written here? Metformin, empagliflozin, glycoside, Bidoron, or switch to liraglutide. The answer is liraglutide. Okay, the answer is liraglutide. Why liraglutide? Because here something is very concerning is this guy's BMI. He has a high BMI. Okay, high BMI. There is more than around 35. And then the next thing that is concerning is he is a taxi driver. So basically, you cannot give any drug. Okay, any drug like a glycoside or an insulin that will actually absolutely going to get him some hypoglycemic episodes while on the wheels. No. So these drugs are out. So metformin is not going to help. Empagliflozin is something okay you can give down the line. But with this situation, the most appropriate intervention will be GLP-1 agonist. Okay, a GLP-1 agonist. Next thing, a 55-year-old woman is diagnosed with type 2 diabetes after being treated for cellulitis affecting her left lower limb. She has a past history of asthma. Okay. She takes salbutamol inhale on the regular and she's on no other medication. BP pulse is fine, chest is clear. She has a BMI of 34 and HbA1c of 67. Which of the following would be the most appropriate initial intervention? This is the lady who's diagnosed first time as a diabetes because she was being treated for cellulitis. During the time she was diagnosed. Now, what is the one drug you will give rationally? Empagliflozin, glycoside, metformin, sitagliptin, or pioglitazone? Only one drug you have to choose. Obviously, it's your good word, metformin. The wonder drug of diabetes, wonder drug for obesity, wonder drug for PCOS. You know, metformin also has some action on cancer cells. How many of you are aware of that? Metformin has some action on cancer cells. Okay, because metformin depletes the glucose that serves as a fuel for cancer cells. There is a trial that went on, and I don't know what has happened to the trial ever that has stopped, right? Metformin has some answers effect on the cancer cells, all right? Next, a patient with long-standing type 2 diabetes is found to have a urinary albumin excretion of 300 milligram per liter. His diabetes is well controlled on metformin and he is normotensive. The blood pressure of 122, his pulse is 65. Abdomen is soft and non-tender. BMI is 32, his HbA1c is 56. Which of the following medication is most useful in reducing the further progression of nephropathy? Which medication will reduce the progression of nephropathy? So you need some medication that acts on the efferent arteriole, leads to its pressure decrease. So the only drug is going to be a lisinopril, right? Lisinopril. 34-year-old accountant is referred to you with a history of diabetes mellitus. Since the age of 16 years, he is a methodical man and appears always to have striven to maintain reasonable metabolic control of his condition while managing a normal lifestyle. What is the most likely finding on examination and routine testing? A raised albumin creatinine ratio, absent angle jerk, anti-thyroid antibodies, background retinopathy, macroproteinuria. What do you think you will find as a person in a good diet control diabetes? You will find macroproteinuria which somebody is having a very good control. They didn't even, this guy's mentioned, she is having diabetes in 16 years. They didn't even mention it's a Modi or type 1, whatever it is. Microalbuminuria, the answer is background retinopathy. Okay, the answer is background retinopathy. And this is also not always common. Okay, I'll tell you, not all the diabetic patients will have all the complications. Some will go for more microvascular, some will go for macrovascular, and some people will be having a predominant autonomic neuropathy. Not everybody will be having this. I don't know which genius has given the question in past medicine. God alone knows. But since for namesake we have to go through that because we are coming through this. All right. Background retinopathy. 21-year-old patient presents with diabetic ketoacidosis. She is known to have a brittle diabetes and has presented 3 times past year. GCS is 12, respiratory rate is 32, BP is 100, pulse 88. She is complaining of epigastric tenderness. To commence oxygen therapy, finger prick blood glucose is 36 milligrams. So what we are dealing with? We are dealing with the DKA. So what is the next step? Subcut insulin, fluid and electrolyte replacement, IV insulin intubation or NG tube insertion. What you will do? DKA case, we have seen enough yesterday, right? We have seen more than 5-6 questions on the same topic. It's fluid and electrolyte replacement. Next question. 54-year-old woman with type 1 diabetes comes to the clinic for her annual review. Her glycemic control has deteriorated. She has been taken a part of Daphne program. What is a Daphne? Anyone knows? Daphne is dose adjustment for normal eating. This is a program in UK. Okay. Somebody, suppose some patient you are prescribing insulin, take Mixtard and nighttime maybe you take Lantus or something like that. If the patient is going on hypoglycemia or the patient is patient's glucose monitor shows the blood glucose are high, for dose adjustments, everything, they just have to enroll in the program. They have some automated thing that will tell them how to, app itself will show what dose they have to go up or down. They have some specialist nurses who will help them and diabetic specialist dietitians. This is a good program in UK. Okay. She has evidence of peripheral diabetic neuropathy and her visual acuity is 6/9 in both eyes. Which of the following findings in retinal photography would warrant an urgent referral to an ophthalmologist? Anybody? C. Which in the 5? A hard exudates, dot and blot hemorrhage, microaneurysm, neovascularization, scattered cotton wool spots. Seeing what, you will immediately write a letter to the ophthalmologist. It's the neovascularization. Because these new vessels that are forming are not the proper ones. They are easily friable. They break and they bleed. This leads to vitreous hemorrhage. Okay. We had an extensive discussion on diabetic retinopathy in our ophthalmology sessions. Okay. Very extensive discussion. How everything, including the pathogenesis, was taken in detail. So neovascularization, if you are seeing in an optic disc, immediately, as per the NICE protocol, you have to refer the patient to the ophthalmologist. Right. Next question. 29-year-old man is brought to ED. He is found unconscious by ambulance service, having collapsed at a darts match. His family history reveals brother with type 1 diabetes. A blood test shows following result: glucose of 1.1 millimole, insulin of more than 500, and C-peptide is low. What is the most likely diagnosis? Do I have to show you the options? And most people will be able to pick it up. High insulin, okay, low C-peptide. What it is? What it is? Insulinoma. High insulin, low C-peptide is insulinoma. How it will be an insulinoma? Insulinoma is tumor of the beta cells. So beta cells will stimulate and secrete excess insulin. So what will happen when beta cell secretes excess insulin? Every insulin is released with the C-peptide. It is like a pair, remember, okay? One insulin comes, along with that, another C-peptide comes. Let it be insulinoma, let it be sulfonylurea, whatever it is, it comes like that only. But when insulin alone is coming, so what it means, it is not coming from your beta cells. It is coming from somewhere else. So this guy has a brother who is a type 1 diabetes. So most commonly, probably what it is. How many questions we have worked out on this? It's a factitious hypoglycemia. So the answer is E, right? Factitious. Never ever make a mistake of answering this as insulinoma. It's an insulin abuse. Be very clear with the concepts, how insulin comes out. If you know that, you won't make any mistakes. 29-year-old woman is undergoing investigation for subfertility. She is overweight with a body mass index of 29. She suffers from acne and hirsutism. She has heavy periods only once in every 3 to 4 months. She wishes to determine whether she is ovulating or not. They are asking which of the following level rises as an indicator for ovulation: estradiol, testosterone, FSH, LH, prolactin. This is a medical student level question. Which hormone will peak during ovulation? There is only one hormone peaks during ovulation. Definitely, not everything. That is your luteinizing hormone. Okay, that's your luteinizing hormone. This is a medical student questions. Never ever make any mistake in that. LH will peak. That is what they call as LH surge, which is an indicator for ovulation. Typically, people who are doing this IVF and all, they do that. Right? They wait for the LH surge. They have some indicators for that. So when there is an ovulation, they will encourage the couples to do intercourse more during the time. Okay. There's a lot of other things, the spin barket, what are the stuffs. I'm not going into in depth of that. Just remember the LH will surge in the ovulation. Now, okay, this is the some 3 lines of complete trash they have written in past medicine. Below is what matters. When looking at cellular process, which of the following enzymes is most likely to be inhibited by improving insulin action? Okay, they are asking when insulin, okay, when insulin comes, it inhibits which enzyme? That's the simple way. Okay, they are just given some stuff up. This is the question they're asking you. Which of the enzyme is inhibited by insulin? Pyruvate carboxylase, glucokinase, glycogen synthase, glucose 6-phosphate dehydrogenase, pyruvate dehydrogenase. Okay, there are a lot of metabolic processes: glycolysis, gluconeogenesis, glycogenolysis. These are the triplet pathway. When insulin comes, it acts on which pathway and does what? Biochemistry, basic sciences. Tell me, anyone. This is the simple question. It goes and does what? One or two basic sciences question definitely you can expect. You cannot run away from that. Okay, you'll definitely expect. What insulin inhibits? It inhibits pyruvate carboxylase. Okay, it inhibits pyruvate carboxylase. Pyruvate carboxylase is what? Pyruvate carboxylase is the key enzyme for gluconeogenesis. What is gluconeogenesis? Production of glucose from non-carbohydrate moieties, right? Production of glucose from non-carbohydrate moieties. So when the pyruvate carboxylase starts, it will start producing more glucose. When insulin comes, it signals, okay, it signals that there is enough glucose, you can shut up and go back. So the enzyme that is inhibited is pyruvate carboxylase. Apart from that, all the enzymes are related to your glycolysis. Insulin stimulate glycolysis. All right. Insulin stimulate glycolysis. Next question. 16-year-old adolescent is seen in endocrinology clinic. He is failing to enter puberty. On examination, pubic hair growth is minimal. Facial hair growth is absent. External genitalia are small. Both testes are normal in size and located in scrotum. Which of the following hormones most drives development of secondary sexual characters? This is nothing other than some story, but this is the question. Okay, they are asking which hormone is responsible for secondary sexual characters. What are the secondary sexual characters? Hair. Okay, the typical male pattern of sexual hair growth, change in the voice, change in the size of genitalia, all these things place. So among this, which of the following hormones drives the development of secondary sexual characters? Anybody? Is it testosterone, androstenedione, dihydrotestosterone, dehydroepiandrosterone, dia, or androsterone? The answer is dihydrotestosterone. Okay, the answer is dihydrotestosterone. Testosterone plays a role, yes, but compared to testosterone, dihydrotestosterone has a 5-fold action. If you keep the ratio, it's 5:1, where dihydrotestosterone with testosterone. Dihydrotestosterone is the hormone that has a higher propensity to activate the androgen receptor than testosterone itself. As a result, if this is the androgen receptor, this has 5-fold increase affinity. So once it binds to that, the secondary sexual character starts developing. Okay, it's dihydrotestosterone and not testosterone. Okay, it's dihydrotestosterone, which has a very higher propensity to androgen receptor and not the testosterone. Okay, this is biochemistry, but we should know that. Also, this dihydrotestosterone also helps in the development of seminal vesicles and as well as prostate gland as well. Okay, it's dihydrotestosterone and not testosterone. Okay, all right, next question. 25-year-old woman is prescribed contraception with levonorgestrel following unprotected sexual intercourse. Her periods have been regular to date. Her last period was 1 week ago. What is the most probable mechanism of action of emergency contraception in preventing conception in this case? All of us would have definitely prescribed OCP to one or the other people we encounter in our day-to-day life. Am I right? So, what is the most probable mechanism of action in emergency contraception? How it acts? thickening of cervical mucus? Does it delay ovulation? Does it decrease tubal motility or ciliary activity? Does it render the endometrium unfavorable for implantation, or it blocks the secretion of progesterone by corpus luteum? How it acts? Yes, Dr. Masjidi, and anybody else? Manal says, yeah. Next, anyone? Just recollect some pharmacology or obstetrics you read during your MBBS life, you will know. Just try thinking, try recollecting. The answer is delay ovulation. What drug they are talking about? They talk about levonorgestrel. The very first thing levonorgestrel does is it delays the ovulation. It completely delays the ovulation. All the other things are done to prevent implantation. There is no doubt in that. But the main mechanism of action of levonorgestrel is nothing other than delays the ovulation. Okay, it delays the ovulation. It's the first line emergency contraceptive pill of WHO because it is available as one of the WHO emergency medication. Okay, almost everywhere it is used widely. This levonorgestrel. All right, everywhere it is used widely. What it does mainly, it's a progesterone. It's a progesterone. It acts as agonist of progesterone receptor. It's an agonist. It acts as an agonist of progesterone receptor. Okay. This, what it does, this primarily, what it does is prevent ovulation by closing of cervix to prevent the passage of sperm. Okay. Because endometrial transformation occurs as a result of it. It also has anti-gonadotrophic action as well. Okay. It also has anti-gonadotrophic action. Okay. Also, this levonorgestrel has a weak agonistic action at androgen receptor. All these things about levonorgestrel, you all should know. And you also, they may ask you about the adverse effect. Okay. Lot of adverse effect of levonorgestrel are there. You guys can go and see. Lot of adverse effect are there of levonorgestrel are seen. Okay. This is very, very important about levonorgestrel. Now, 30-year-old school teacher is on a combined OCP containing 20 microgram of ethinyl estradiol. She is asking about its possible adverse effect. What is the most common, or which of the following is the side effect most likely to occur with estrogen only pill, estrogen in a combined pill? What is the adverse effect? Does it cause DVT, nausea, increased ischemic CV events, breakthrough bleeding, migraine? They are asking side effect most likely to occur. Okay, combined OCP can cause thousands of side effects, but they are asking which is the most likely adverse effect here among all. Anybody? Anybody? Come on. Think. Okay, breakthrough bleeding. Like I always say, MRCP has more than one right answer, without doubt. Without doubt. The question is, which is the most common adverse effect of combined OCP, especially estrogen in combined OCP? What it does, doctor? Most common ADR, okay, is the breakthrough bleeding. Excellent. Combined OCP can lead to many things. It is a thrombogenic drug, right? It can cause your thrombo DVT, it can cause pulmonary embolism. That's why in patient's examination in personal history, they always tell triple P you have to ask in patients. That's what we always teach them. Triple P we ask. What is the triple P? In lady, whenever you are encountering a female patient, pregnancy history, okay, how is the periods, and is she using any pills? This is called triple P history. Periods, pills, pregnancy. And especially in pregnancy, any abortions are there, because first trimester abortions, there are certain conditions that causes that. Second trimester abortions, there are certain conditions that causes second trimester abortions. So we have to ask the triple P. The most common OCP adverse effect which contains estrogen is breakthrough bleeding. Okay, all the ischemic event, migraine, everything is next. They're asking the most likely event. Okay, all right. The question is down. Which of the following actions of glucagon are most associated with rapid reversal of hypoglycemia? You should all know the treatment of hypoglycemia. Now, I'm not going to teach you that. But in the case of hypoglycemia, what does glucagon does to rapidly reverse it? Does it increase glycogenolysis? Does it induce a synthesis of phosphofructokinase? Does it stimulate acetyl-CoA carboxylase? Does it promote the formation of ATP from cyclic AMP? Or does it activate adenylate cyclase? Who will answer me the question? Yes, there is some disconnection. I'm sorry. Yep. So what it does? So most people answered A. Let us see the answer. Okay, sorry. Yeah. The answer is E. Okay, the answer is E. It activates adenylate cyclase. Okay, because this adenylate cyclase involved in glycogenolysis. What it does, this AC does is it acts this, it starts breakdown of glycogen. Once glycogen breaks down, it forms multiple glucose molecule. Okay, multiple glucose molecule. This adenylate cyclase is the enzyme that gets activated. So multiple glycogen stores will be get broken down. Okay, multiple glycogen stores in the body. Where are all the glycogen stores in the body? It is in your liver, it is in your muscle, it is almost everywhere. So this multiple stores gets broken down. As a result, I'll tell you, multiple stores get broken down. So multiple glucose molecules will come that will compensate it. What they are asking about rapid reversal is what they are asking. Yes, glycogenolysis in the muscle will increase, but what happens rapidly? Initially, rapidly means what? As soon as you glucagon enters, what it does? Does it goes to the muscle directly and acts? No. As soon as it goes, it activates your adenylate cyclase. Then the adenylate cyclase will go to multiple areas. The fastest breakdown occurs in the hepatic glycogenolysis. Okay, the hepatic, that the glycogen stores in the liver gets broken down faster than the muscle. They are asking about rapid reversal. That's why MRCP question always have multiple right answers. It does that? Yes, it does. A is right. Yes, A is right. But the question that has been asked is which is the responsible mechanism for rapid reversal, quickly to reverse it, what it does. That's the answer. Okay. The next question. We are going to go for the next question. Yeah. I'll just change this color. Yeah. A 47-year-old woman is there. She's undergoing investigations for secondary amenorrhea and joint pains. Blood shows her FSH to be 40. And she's a non-smoker with a BMI of 24. FRAX score is calculated and it shows intermediate risk. She subsequently takes DEXA and the T score is 0.8. What is the most appropriate way for managing this patient? So see the question. What is the patient? She's a 47-year-old lady. She has secondary amenorrhea. She has some joint pains. Her FSH levels are 40. She is a non-smoker, they're telling. Her BMI is 24. So you are doing a FRAX score. What the FRAX score reveals here? The FRAX score reveals she is having intermediate risk. DEXA is 0.8. So what you will tell her? Health and lifestyle, active lifestyle, raloxifene, risidronate, strontium renalate, teriparatide. The answer is A. Okay, this is just a primary prevention. She didn't have any fracture. Frac score is not high, and DEXA is not significantly following in a osteoporotic range. So just advise her for a healthy lifestyle. 70-year-old man admitted to the hospital in a comatose condition. His wife gives a history of episodes of sweating, palpitation, confusion, and fits, and occasional abnormal behavior. He gained 4 kg weight over the past 5 months due to persistent hunger. On examination, his BMI is high, blood glucose is low. What is the likely diagnosis in a 70-year-old man? Just correlate whatever I have underlined and come to a diagnosis before we see the options. Okay, if you can come to a diagnosis here itself, then you won't get confused with options in the MCQs, which you are going to face in your exams. Men to pheochromocytoma, insulinoma, pseudodementia, epilepsy. Definitely this too is not there and this is not there. So cancer is your insulinoma. What says that? He has hypoglycemic symptoms. Hypoglycemia mainly causes sweating, palpitation, confused, and abnormal behavior. Okay. His BMI is also increasing because overeating. Because he gets hypoglycemic, he starts eating. Have you seen people with hypoglycemia eating? They will go in the same way how people who takes cannabis they eat. They call it munchies in cannabis addicts. Once they start taking cannabis, they gets this kind of this intense hunger. They just go around, just eat anything they have. 40-year-old man is receiving lithium for bipolar disorder. Now complains of increasing urinary frequency and nocturia. He has taken medication for some 7 years. He has also taken risperidone and has gained 7 kg in weight over the past year. Post-water deprivation test, plasma osmolality rise to 320 and urinary osmolality is 280. What is the diagnosis? You have seen already. I have already put a table also and explained you. The core concept lecture also I did. Yesterday also I have done the same thing. So what is the diagnosis here, doctors? A person on a drug, lithium, passing excess urine. There is only one diagnosis here. What is happening? Is it due to deficiency of vasopressin, or is it due to reduced creatinine clearance, onset of thyrotoxicosis, or development of resistance to vasopressin, or excessive water intake? Now, is it A, B, C, or D? Yes, the answer is D. This is due to development of resistance to vasopressin. Yes, fantastic. Exposure to darkness found to be increasing the melatonin secretion. Okay, you consider recommending blah, blah, blah to 17-year-old man with severe autism. What they're asking, most common mechanism by which melatonin is naturally synthesized. How many of you know about melatonin? Any one of you is prescribing melatonin for people? Melatonin supplementation? How the melatonin is synthesized? Okay, for sleep therapy. Yeah, you can give it as a supplement. It's synthesized by increased serotonin N-acetyl transferase. The answer is B. This is clinical pharmacology, but still they are asking because these days a lot of interest is there in melatonin and related drugs. A lot of people are doing a lot of research on this. So the answer is B, increased serotonin N-acetyl transferase. Now, 27-year-old woman is presenting with polyuria. is found to have diabetes insipidus after a motorcycle incident. Which part of the nephron is most affected? The answer is increased serotonin N-acetyl transferase. I hope all of you know melatonin is synthesized from your pineal gland. Okay, pineal gland. In the pineal gland, increased serotonin N-acetyl transferase activity lead to release of melatonin. Now, a 27-year-old woman presenting with polyuria is found to have diabetes insipidus. So, which part of the nephron is most affected in this condition? Proximal tubule, cortical and medullary tubule, distal convoluted tubule, thin ascending limb, or glomerular afferent arterioles. Where this aquaporin channels are located? If you know that, you will answer this. This is a physiology question. Anybody? Come on, give an attempt. A proximal tubule. After this is the nephron. Your proximal convoluted tubule, ascending limb of descending limb of Henle, distal convoluted tubule, you are collecting that. Where is the problem? What is the problem? Problem is with water. The answer is B. Okay. Collecting duct, collecting tubules are two. One is a cortical and another one is a medullary collecting duct. Both as aquaporin channels. The antidiuretic hormone comes and acts on ADH receptor and aquaporin channels and increase in water reabsorption. In nephrogenic diabetes mellitus, this is gone. This action is gone because there is resistance here. So the action is going to be in your cortical and medullary collecting tubules. Little revision of nephrology. 55-year-old man is coming with a history of ischemic heart disease and type 2 diabetes, is presenting to the emergency department with shortness of breath and decreased exercise tolerance. On examination, his blood pressure is 155/82, pulse is 88, BMI is 35. You confirm bilateral basal crackles consistent with heart failure. On auscultation of the chest, there is also a pitting edema of both the ankles. He takes a number of medications for diabetes and hypertension. Which one of the most following is likely to be associated with heart failure? They are asking which of the following is likely to be associated with the heart failure. That's what they are asking you. So which one of the following? Amlodipine, dapagliflozin, indapamide, metformin, or saxagliptin, which is associated with heart failure? Which is the drug associated with the development of heart failure? Okay. The answer is saxagliptin. No, not B. Don't answer B because this is now indicated for heart failure. This is indicated for heart failure. Indapamide. What is an indapamide, doctors? It's a diuretic. Again, diuretics are prescribed for what? Heart failure. Amlodipine again can be used. The culprit drug is saxagliptin. Sometimes some of the gliptins are known to cause heart failure. Now, 29-year-old woman who is 12 weeks pregnant presents to the endocrine clinic which suppressed TSH, that is less than 0.05, a markedly elevated T4. She has positive antithyroid antibodies and a smoothly enlarged thyroid on palpation. She has increased resting pulse rate of 95 beats per minute. Which of the following is most appropriate initial investigation? We have already seen extensively. Yes, DDP4, saxagliptin, vildagliptin, linagliptin, teneligliptin, what are all gliptins are there? Which of the following is the most appropriate initial intervention in this case? The person in pregnancy with the goiter, with positive antithyroid antibody, what he will do next? What is the next intervention he will do? She is pregnant. Will you give radioactive iodine? Will you give propranolol? Will you give propyl thiouracil? Will you give carbimazole and thyroxine? Mind, she is 12 weeks pregnant. Or will you go for a surgical resection? The answer is yes, D, propyl thiouracil, because this is a time of organogenesis, so we have to give that. Later point of time, you can switch over to carbimazole. It's not A at this point. 40-year-old man is identified as in a well-man clinic. He is having obesity, impaired fasting glucose, and hypertension with a blood pressure of 155/95. Hypertension is confirmed over the course of 3 months. BMI is stuck at 33. Which of the following antihypertensive drug you must avoid in this patient? Somebody with obesity, IEFG, impaired fasting glucose, hypertension. Which drug is contraindicated or you will avoid? Losartan, lisinopril, hydrochlorothiazide, indapamide, bisoprolol. You tell me an option and give me an explanation why you will avoid that particular drug. Right, we should give explanation why you will avoid that particular drug. Anyone? Come on, give your attempt. They're asking why you avoid the drug. He is hypertensive, he is obese, he has impaired fasting glucose. So what they are worrying about, what are the things he is having? Why is so much hesitation to answer this? He is having hypertension, he is having obesity, he is having impaired fasting glucose. What they are worried about, there is some drug here that could affect one of the thing. Either this drug could cause hypertension. Unfortunately, none of the drug will cause hypertension. Whether some of the drug can cause obesity or some of the drug will increase the blood sugar levels. Definitely not lisinopril or losartan, I believe. Okay, definitely not those drugs. The answer is hydrochlorothiazide. Okay, hydrochlorothiazide. Okay, because acid diuretic are notorious to impair glucose metabolism and leading to insulin resistance. So thiazide diuretics are generally not preferred in diabetic people, okay, or someone with impaired fasting glucose. 39-year-old man is seen for a follow-up appointment in the endocrinology. He has Graves' disease, managed with block and replace regimen. He has a goiter, third tracheal compression. He is considered for subtotal thyroidectomy. What is the most common post-operative complication following subtotal thyroidectomy? Recurrent laryngeal nerve palsy, chronic hypoparathyroidism, hyperthyroidism, tracheal compression, hypothyroidism. Following a subtotal thyroidectomy, what do you expect to happen? They're asking the most common post-operative complication. All this can occur. What is the most common? The most common complication following a thyroid surgery is nothing other than your hypothyroidism, E. Okay, most common complication following a thyroid surgery is hypothyroidism and nothing else. 17-year-old boy presents with concerns that he is not entering puberty. His past medical history note, there is a decreased sense of smell. I will stop here. What is the diagnosis? What is the diagnosis? You don't need to go and think so much here. This is your good word, Kalman syndrome, right? Kalman syndrome. Next, 18-year-old girl presents to the ED with episodes of shortness of breath, especially on exercise. Parents have to be reluctant to use medical services for themselves or children. Therefore, this patient has never been registered with the GP. In UK, all of us have to register with GP. Even I have to register with GP. I have been registered with the GP. Okay. And on examination, the blood pressure is 155 by 88. Pulse is 82. She has a systolic murmur. You also note short stature, webbing of the neck. She tells you she never had a menstrual cycle. What is the diagnosis for short stature, webbing of neck with a systolic murmur? What is it? Short stature, webbing of neck with a systolic murmur. What is it? Turner's. Right. Now, a Turner syndrome patient is coming to you. She's telling she didn't have a period yet. So what do you like to do for her? What would you like to do for her? Put on your thinking hats and tell me, what would you like to do for her? Anyone? Anyone? Come on, try. No try. You'll give growth hormone, you'll give progesterone, estrogen, pulsatile, GnRH, or LH. The answer is estrogen replacement. Okay? Estrogen replacement. First thing you should be worried about her development of secondary sexual characters. That's the very first thing you should do. Also, it will help with protection from complications like osteoporotic fracture. In this case, you have to replace the estrogen before going for anything else. All right. 17-year-old girl presents to endocrine clinic with primary amenorrhea. She represents her high school in athletics, does train frequently. Physical examination shows PMA is 18.5. What is the most appropriate intervention for her? We have seen so many similar cases like this yesterday in past questions. Yes, somebody who is an athlete, she's training herself rigorously and she is getting a primary amenorrhea. So what kind of intervention you are going to do for her? You got the diagnosis. You will give estrogen, you will give gonadotrophin releasing hormone, you give gonadotropins, or you will adequate diet or gradual weight increase, or will you prescribe estrogen and progesterone? What are you going to do as a physician for her? Fantastic. The answer is D. This is because of the poor diet and excess control. You have to put her on diet and exercise. And also, if needed, she may need some psychological counseling as well. All right. Next, 45-year-old woman presents with recurrent heavy periods, pain associated with her monthly cycle. Which of the following hormones is most likely associated with shedding of endometrium during menstruation? Go back to your physiology. Tell me, how many of you remember your physiology? Which hormone is responsible for shedding of the endometrium? LH, FSH, GnRH, progesterone, estrone. Answer is progesterone. Progesterone is the hormone that causes shedding of the endometrium. Because how it does? It acts on the endometrium and it causes shedding because. Okay. Next question. 30-year-old man is referred to the ED after a road traffic accident. He has suffered from gradually increasing tiredness. Okay. For the past 4 months, he also split from his long-term girlfriend after problems with erectile dysfunction. On examination, what is the significant finding is he is having a bitemporal hemianopia. Testosterone is low. Prolactin is tremendously high. MRI showing a pituitary tumor of 12 millimeter. So now they are asking what is the diagnosis. Here is a guy, 30 years old, gradually increasing tiredness. He's also having erectile dysfunction. He is also having bitemporal hemianopia. It means what? Something is compressing the optic chiasm and whatever compressing is a big one. So what is this? It could be a somatotropic adenoma. Could it be a prolactinoma? Could it be a basophil adenoma? Is it a non-functioning pituitary tumor? Or is it a craniopharyngioma? The answer is a prolactinoma. Why it is a non-functioning pituitary tumor? A non-functioning pituitary tumor will not secrete this much levels of prolactin. Am I right or wrong? A non-functioning pituitary tumor will not secrete this much levels of prolactin. A non-functioning pituitary tumor will not cause decrease in your testosterone. The name itself is what? Non-functioning, right? Yes. 50-year-old man is here coming. He is treated with metformin for his diabetes. He is presenting with malaise and loss of libido. He takes regular non-steroidal anti-inflammatories for osteoarthritis for both knees. He has multiple spider nevi and hepatosmegaly. His fasting glucose is high. His serum iron levels are high. Serum ferritin is tremendously high. What is the most appropriate treatment for loss of his libido? What is the diagnosis first? What is related to road traffic accident? Somebody is asking. What exactly you are trying to ask, doctor? What is related to road traffic accident? I'm not getting you. All right. So, what is the treatment you are going to give? What is the diagnosis here? The diagnosis is very good. It's hemochromatosis. Otherwise, the other name is bronze diabetes. Okay. So, what do you do here? What will you do to help him to get back his libido? Testosterone replacement, desferoxamine, sildenafil, insulin, or liver transplant. 5, 4, 3, 2, 1. Come on, quickly think. The answer is testosterone replacement. Yes, this is the only thing you can do. About the road traffic accident, there are a lot of things you will find in past test and past medicine question. Not everything is significant. That's why whenever you are approaching a question, you have to underline what is significant and what is not significant. Because sometimes what they will do is they will keep a question like pituitary apoplexy or some pituitary injury or cranial bleed, so to confuse people. So whatever is given, they can give you anything, but you have to note down what is important and not just everything. Desferoxamine helps, but what they are asking the treatment of loss of libido. They are not asking you the treatment of hemochromatosis. Okay, desferoxamine is not going to help you with the libido. Yes, it does helps in the disease progression, but he is only worried about libido. The question is asked on libido. Everything is important here. Liver transplant also at the end of the day, he is going to get sildenafil you can give. But ultimately, to up the libido, you have to give testosterone, right? 18-year-old woman with primary amenorrhea comes to the endocrine clinic. She is concerned that her periods have not started. Only history is bilateral inguinal hernia repair as an infant. Breast development is normal. She has absent pubic and axillary hair. What is the diagnosis, doctors? Yesterday we told whenever you encounter a bilateral inguinal hernia with amenorrhea means what is that? This bilateral inguinal hernia is nothing other than what I told you. Is an undescended testis. We discussed about this yesterday. Very deeply we discussed. Is it androgen insensitivity syndrome, autoimmune ovarian failure, Kalman syndrome, Klinefelter syndrome, or Turner? It's androgen insensitivity syndrome, not CAH. CAH, how people will present. CAH, who are all told CAH to me. CAH, how? There are two forms. One is non-classical and classical. Am I right? Non-classical is in infancy. They present as cerebral salt wasting pattern. Am I right? Classical is presently clearly. CAH is what? Congenital adrenal hyperplasia. What it does, it causes precocious puberty. Don't ever confuse with androgen insensitivity syndrome. Whenever you notice words like amenorrhea, whenever you encounter some tips or pointers that says the gentleman has congenital or in infant inguinal hernia, always it's going to be AIS unless proven otherwise. All right. Let's take a 10 minutes break. I need 10 minutes break to keep my voice intact. Not 10 minutes, a 5 minutes break we will take and we will again be back. 5 to 7 minutes break we will take and again we will start discussing. Okay. All right. Thank you. Thank you, doctors. How many of you guys are here? I'm back here. We will start in a minute. Hmm. Okay, let's begin without further delay. Next question is a 40-year-old man presenting with headache, excessive sweating, galactoria, polyuria, polydipsia. He says that he can no longer wear his wedding ring because his fingers have become swollen, visual field defects. She shows bitemporal hemianopia. Should I need to tell other things? He is having high fasting blood plasma glucose. His prolactin is high. What is the most probable underlying diagnosis? Just by seeing the things which you are seeing in the screen, you guys should be able to tell what is the diagnosis. This is not a so hard one to diagnose. Somebody with galactoria, excessive sweating, headache, his wedding ring size is going up. He's having bitemporal hemianopia. What is it? His blood pressure is going up. Come on, there is not a lot of things here. This is your good old acromegaly. What is there to think? What is there to think even? Straight away, straightforward question. This is your good old acromegaly. All right. Next question. 17-year-old boy who is 155 centimeter tall is worried he might have stopped growing. So what they are asking, which hormone is chiefly responsible for epiphyseal fusion and cessation of growth? Any idea? Anyone knows which hormone is responsible for epiphyseal fusion and cessation of the growth? Which hormone? Excellent. It's estrogen, Dr. Manal. Fantastic. It's estrogen. Estrogen is the hormone is responsible for epiphyseal fusion, especially in the long bones. All right. Many people think it's androgen. It's not androgen, it's estrogens. All right. Estrogen is responsible for epiphyseal fusion, and this will lead to further stoppage of growth spurt. Next question. 27-year-old man is found to be having oligospermia. He has normal male phenotype, including secondary sexual characters. Blood test shows testosterone is 30. It's in the normal range. LH is 10. It's okay. FSH is low. Which of the following most likely to be the cause of the oligospermia? If you are finding a person like this, what do you will think? What is the most likely cause of oligospermia in this particular gentleman? Increased inhibin, decreased androgen binding protein, decreased dihydrotestosterone, deficiency of androgen receptor, or hypothalamic disorder. What is happening here? Come on, others contribute. This is an MCQ workout session. I want to interact with you all and I want all of your answers so that we will get to know and learn together. Any idea what is this? The answer is decreased androgen binding receptor. What is happening? We will come to the biochemistry. His three things they take: testosterone, LH, FSH. All right, testosterone, LH, and FSH. His testosterone is relatively normal. LH is, I would say, rather kind of in the higher end of the normal range, right? It's in the higher end of normal range, where the FSH is low. What it signifies to you? Anybody? What it signifies, this pattern? No idea? This signifies normal level of LH and FSH alone is low. So what it signifies? See, again, I will draw another diagram and I'll explain you quickly. This is your brain, maybe this is your hypothalamus, and this is the male gonads. Okay, what comes from here? FSH and LH comes and acts here. Okay, LH here is surprisingly normal, but FSH is low. Okay, FSH, if it is low, FSH alone is low. What does that means? There is some decrease in androgen binding protein, because why is the FSH, the androgen binding proteins are less. The FSH will definitely get a feedback and it will automatically become low, where the LHS is normal. So you cannot call it as a hypothalamic disorder because LH is normal there. There is no way there is going to be decreased and dihydrotestosterone. There is no way there is going to be increased inhibin. The two options here are androgen binding protein and androgen receptors. The answer is androgen binding protein deficiency here. When there is a deficiency in androgen binding protein, this will lead to decreased FSH alone. As doctor, the question is simple. Three parameters. Testosterone is normal, LH is increased, and FSH alone is low. At least even if you don't understand the entire concept, just know some basics. A pattern like this signifies deficiency of androgen binding protein and not a hypothalamic disorder. LH is because LH is also coming from hypothalamus, so there is no central point of view. But FSH alone is decreasing because lack of feedback, that is due to decreased androgen binding proteins. Okay, decreased androgen binding protein. That's where you get FSH, isolated decrease in FSH, but LH will be normal and testosterone is normal. Next, 17-year-old girl presents with primary amenorrhea. Past history include bilateral inguinal hernia. Okay, she has normal breast development, pubic axillary hair are virtually absent. 46XY genotype. What is the diagnosis? Again, just now we had discussed. What is the diagnosis? What is the diagnosis here? This is nothing then only AAS. Now they are asking the cause of AAS. Is it due to lack of testosterone formation? Or is it due to decreased 5-alpha reductase? Or is it due to increased aromatase synthesis? Or is it due to lack of dihydroxytestosterone receptor? Or is it due to total lack of testis? What is the answer? The answer is lack of dihydrotestosterone receptor. That is why it is called androgen insensitivity syndrome. Means what? Androgen is coming, but there is no DHEAS receptors are there, or very few is there. It's trying to act, but receptor level is scanty. That's why it is called androgen insensitivity syndrome. 25-year-old woman presents with recurrent episodes of headache, sweating. Her mother had a renal calculi and died of a tumor in neck. On examination, there is a nodule felt in the patient's neck region of the thyroid gland. Routine blood cells are unremarkable, and histology reveals small round cells positively for calcitonin. So first, what is the diagnosis? Before we read the question, what is the diagnosis here? Come on, tell me. Renal calculi could be due to increased parathyroid hormone. Calcitonin. Which thyroid malignancy will cause increase in calcitonin? Which thyroid malignancy? Medullary thyroid carcinoma. So combining this together, what is the syndrome? What is the syndrome where you have hyperparathyroidism, medullary thyroid carcinoma, which is proven by increased calcitonin? Men 1. No, doctor, don't hurt me by telling me men 1. It's men 2. Men 2A, to be honest. Okay. What is the most important investigation the surgeon should do before taking prior to surgery? Serum thyroxine, serum calcium, 24-hour urinary 5-hydroxy indolacetic acid, 24-hour urinary metanephrines and catecholamines, or serum calcitonin. So we know the diagnosis is meant to. Okay. So here we have your parathyroid tumor, you have your MTC. What other things you will have in men 2A? What other thing you will have in men 2A? What other thing? Doctors, yesterday we saw it's pheochromocytoma. So what other thing surgeon has to rule out? Pheochromocytoma. So the answer is D. All right, the answer is D. 22-year-old man presents with episodes of headache, tremor, and sweating, which can last a considerable period of time. He has a history of epilepsy since childhood. He is on different antibiotics. He has a large portwine nevus on the side of his face. What is the diagnosis? Epilepsy plus portwine stain on face. Childhood epilepsy. There is not a lot of things that presents like that. There is only one condition that presents like this. That's why I wanted the diagnosis straight away from you without seeing the option. There is only one condition where the patient will have epilepsy since childhood and as well as a portwine stain in the face. There is only one condition. That condition is called your good old Stooge-Weber syndrome. Fantastic. Yes. All right. It's called Stooge-Weber syndrome. Portwine nevus, childhood epilepsy. Don't forget, if you get something like that, Stooge-Weber syndrome. 40-year-old woman who has been prescribed metoclopramide for persistent nausea comes to the surgery for review. She says she has nausea. Her nausea has been involved, but she now has a milk leakage from both the breast, loss of libido, and has not had periods for the last 4 months. What is the mechanism of action of metoclopramide? Doctor, the last question is, somebody asked, what is the last question? Last question is simple. Childhood epilepsy with portwine stain on face. There is only one diagnosis. Very straightforward. It's Stooge-Weber syndrome. All right. Now the next question. Somebody's taken metoclopramide and she started having galactorrhea. Obviously, metoclopramide can cause galactorrhea. So what action of metoclopramide driven the symptoms? Stimulates dopamine release by hypothalamus, or directly stimulate pituitary lactotropes, or bind to D2 receptors on pituitary lactotropes, promotes pituitary adenoma growth, or inhibits LH secretion by the anterior pituitary. What is the answer? What is the answer? The answer is C. Binds to D2 receptors on pituitary lactotropes. C. The prolactin is inhibited by dopamine. When D2 receptors are blocked, what happens? Dopamine is no longer going to be there. When there is going to be no longer dopamine, what will happen? Prolactin will become more. More the prolactin, more the galactorrhea. 25-year-old man is admitted to the emergency department having consumed 20 tablets of propranolol. He is hypotensive and the blood pressure is 80/50. An infusion of glucagon is prescribed. What is the mechanism of action of glucagon with respect to resolving bradycardia? We all know beta blocker overdose. We give glucagon. I hope all of you know, right? So what mechanism of action of glucagon will prevent bradycardia? Where it acts? Just see the MCQ and think logically, you can answer. By stimulating lipolysis, will bradycardia be countered? No, right? By increasing glycogenolysis, bradycardia will be countered? No. By promoting gluconeogenesis, will bradycardia will be counted? How by promoting gluconeogenesis, bradycardia will be counted, doctor? By giving more glucose into the system, will the heart will stop bleeding slowly? How? It promotes the formation of cyclic AMP. So once the more the cyclic AMP, it will increase the heart rate. So bradycardia will be counted. Simple thing. Which other thing will increase your cyclic AMP? Which other thing will increase your cyclic AMP? Other thing that increases your cyclic AMP is nothing other than your good old coffee. Yes, I'm sorry. There is some disconnection in the net. Yep. Can you all hear me? So this is done by formation of cyclic AMP. Okay. Cyclic AMP. I hope now you guys can hear me. All right. Let's go. Next question. 50-year-old man is presenting with a history of panic attacks, palpitation, sweating, headache, and flushing. On examination, pulse is 120. Pulse is 120. On examination, the pulse rate is 120. And blood pressure is 190 by 110. Urinary catecholamines are elevated over 24-hour period. Noradrenaline is mostly elevated. Initial ultrasound scan of the abdomen reveals no masses. CT scan of the abdomen does not show any adrenal mass. Okay. Which of the following tests would be most useful in establishing the I am so sorry again for the poor internet connections. Internet connection is actually good. There is some repair work going on all over the place where I live. They are just reinstalling some new towers. So in the name of testing, they are just doing something with the 5G towers. As a result, network is coming on and off. Okay, let's stick with the same question. Same thing. So what is the diagnosis here? What is the diagnosis here? Somebody said carcinoid syndrome. How carcinoid?
Pheochromocytoma.
Diagnosis is pheochromocytoma. Not carcinoid syndrome. Carcinoid syndrome will present with what? Doctor, right now I am not in UK. I'm back in India. I'll be going back shortly. Net issues does happen there whenever there is, especially in Scotland, we do have. Okay. So, what happens in a carcinoid syndrome? Yes, pheochromocytoma can happen without adrenal mass. I will tell you how and why. Carcinoid syndrome, what is the one finding you will have? You'll have a diarrhea, doctor. So to make sure this is pheochromocytoma, what one test you will do? What is the one test you will do? There is only one test you will do. I mentioned in the core concept lectures, it is E. Okay, it is E. It can be an ectopic extraadrenal tumor. Sometimes it may not be always visible in a CT or MRI. How much is the size of your adrenal glands? Very minimal. Sometimes it can be missed out. So the best thing is MIBG scan. Is the best thing. Okay. Now, 28-year-old woman comes to the clinic for review. She developed polydipsia, polyuria while undergoing treatment with lithium for a bipolar disorder. Now she complains. She then switched to sodium valproate. Despite this, she still complains of the symptoms. Even though she is having low sodium diet, her BP is 110 by 70 with a drop of 10 millimeter of mercury on standing. What is happening here? Her potassium is high normal, right? It is 5. That is what you call it as a high normal, like I explained yesterday. Low normal and high normal. Her urea is increased. Her thyroid stimulating hormone is though slightly on the lower end. What else is happening? Her glucose is fine. What is happening to her? What will be the next investigation? She's having some postural drop of hypotension of 10 millimeter of mercury. She had bipolar disorder and then she developed some diabetes insipidus. And as a result of the diabetes insipidus, she stopped the lithium and went for sodium valproate. After taking sodium valproate, now she is complaining of the symptoms still going on. Still, she is having polydipsia, polyuria, and she is having postural drop. What do you think is happening to this lady? Any idea? What will you do? What will you do? You give a thiazide, you give demiclocycline, you give furosemide, you give sildenafil, you give V2 receptor antagonist. What is the drug you will give? Sildenafil. Oh, no, definitely not sildenafil. Their major problem right now is what? What you will give? You will give a thiazide diuretic. This is a diagnosis of nephrogenic diabetes insipidus. Even after stopping the drug, the symptom can persist for a while. Just remember, just because someone discontinued lithium, they may not be completely free of the nephrogenic diabetes insipidus. They may have the persistent symptoms. So the drug you have to give is a thiazide diuretic. They are the treatment of choice for nephrogenic diabetes insipidus. Somebody wanted previous question. Previous question is about pheochromocytoma. Maybe due to net disconnection, some of you may have missed. It's a question on pheochromocytoma. If you have all the symptoms of pheochromocytoma with elevated urinary catecholamines or fraction plasmametanephrines, but you don't find a mass in the scan, in the radiograph, you have to do MIBG scintigraphy. That's all is in a conscience. All right. 18-year-old man comes to the clinic complaining of polyuria, polydipsia, 3 weeks after discharge following a motorcycle accident. He sustained a head injury and was knocked out approximately 10 minutes. On examination, BP pulse is fine. There is a blood pressure drop of 20 millimeter of mercury on standing. Okay. What the investigation shows here, what is abnormal? Bicarbonate is slightly low. Creatinine is on the higher end of the normal range. Urea is high, could be due to bleeding or anything. What is the likely diagnosis? In a patient sustained head injury, following a head injury, the patient is having polyuria and polydipsia. The answer is your good old cranial diabetes insipidus. Okay, cranial diabetes insipidus. The last question we saw is a nephrogenic diabetes insipidus. So the treatment of nephrogenic diabetes insipidus is a thiazide diuretic. So what is the treatment of cranial diabetes insipidus? What is the treatment of cranial diabetes insipidus? Quickly. How do you treat cranial diabetes insipidus? Quickly. Anybody? Yes, desmopressin. Fantastic. 70-year-old diabetic man being treated with ramipril, furosemide, and bisoprolol for congestive heart failure is admitted in a comatose state. According to the neighbors, he has not been seen out for the past few days. Examination reveals BP of 90/50 and pulse 88 beats per minute. Then what else is happening here? His chloride is high, potassium is high, and his glucose is tremendously high. And pH is on the low normal end. Creatinine is raised. He is taking metformin. What is the diagnosis? So this kind of patient is coming to your ICU. 70-year-old diabetic guy. He's taking ramipril, furosemide, and bisoprolol. He is in a comatose state. High blood sugars, 50 millimole. BP is tremendously low. pH is quite on the lower end of the normal range, but still in the normal range. He's taking metformin for his diabetes. What is the diagnosis? DKA, drug overdose, acute stroke, hyperkalemia due to angiotensin converting enzyme inhibitor. Will it produce something like that? No. There is nothing significant of drug overdose. Still keep acute stroke, no. DKA, the pH should be what? Low. The answer is hyperglycemic, hyperosmolar coma. pH is not that low. Bicarbonate levels are decent enough. So the answer is hyperglycemic, hyperosmolar coma. So how do you treat? Rehydration and insulin is required in the acute phase. 25-year-old woman being investigated for multiple endocrine neoplasia type 2B. She is also noted to have morphonoid feature. What will be the likely finding is meant to be? What we discussed in meant to be? Elevated calcium, elevated metanephrine, elevated thyroxine, decreased parathyroid, elevated glucagon. What is that? Quickly, because these questions are now we can brush up fast. You know what is meant to be. What is other thing in the meant to be? What is the other thing you will find here? Your pheochromocytoma. So you will check for elevated metanephrines. Next question. 28-year-old woman comes to the fertility clinic for review. Her partner has 3 children from a previous relationship. Yet despite trying for a child for a year, she is unable to get pregnant. She keens to know about the time of ovulation. This is why MRCP, some things will be irrelevant. Is it anything significant if her partner has 3 children with a previous relationship? Does it going to benefit you or me, or does it going to alter her diagnosis? Nothing. Which of the following investigation is most likely to indicate that ovulation is imminent? Follicle size of 20 millimeter, increased basal body temperature, positive spin barket, secretory changes on endometrial biopsy, or a raised LH level. Quickly, what is the answer? You know. What happens in ovulation? Yes, basal body temperature and all increase, but they are asking, what is the investigation? What is the investigation? What is the one thing that will signify that patient is going to ovulate shortly or ovulation is imminent? There is only one thing that will say. Obviously, raised LH level. We just saw the question some time back. Again, the same concept is reinforced here, nothing else. 18-year-old woman in an endocrine clinic came with review after recovering from anorexia nervosa, which she has suffered for the past 3 years. Her periods are not commenced. Which of the following would be the most typical of the first sign of onset of puberty? What is the very first sign of the onset of puberty in a girl? Pubic hair growth, height spread, breast bud development, axillary hair growth, menarche. What is the first sign of puberty in a girl? Simple questions, right? Just unnecessary details will be there up. Don't get worried about those details. Read through the lines. The answer is breast bud development. They call it as talarche. Typically occur between 9 and 12 years of age and continues up to 12 to 18 years of age. 55-year-old chronic smoker presents with polyuria, polydipsia, and altered sensation He is known to be suffering from squamous cell carcinoma of the lung. On examination, he is lethargic and confused. And electrocardiography shows narrowed QT interval. What is the most probable metabolic abnormality? Altered sensation, polyuria, polydipsia, narrow QT interval. What is it? Altered sensation, polyuria, polydipsia, narrow QT interval. What it is? Very good. Increased calcium. And what happens in squamous cell carcinoma? It secretes PTHRP, which will increase calcium. All right, it increase calcium. So the answer is hypercalcemia. Right, the answer is hypercalcemia. Next question. 18-year-old woman comes to the endocrine clinic for review. She complains of excessive hairiness and acne and irregular heavy periods every 2 months. She takes no regular medication. Examination reveals BP of 122/82. And pulse is 74 beats per minute. Her BMI is 23. You confirm facial and upper chest acne with increased hair growth around the beard line, around the nipple. A lady with androgenic feature, excess acne, heavy periods. What is it? Her testosterone levels are high. 17-hydroxyprogesterone is even higher. Which of the following is the likely diagnosis? The answer is non-classical adrenal hyperplasia. I don't understand why a lot of people went for PCOS after seeing the biochemistry. She has androgenic features, no doubt. See the biochemistry. I just marked it. That's why I thought some of you may at least clinch that. After marking, I thought somebody will clinch. This is a non-classic adrenal hyperplasia. Many people just on a knee-jerk reaction, seeing this, okay, lady coming with excessive hairiness, acne, irregular period, high BMI, quite high BMI, acne is there, hair is there. Okay, this is PCOS. Yes, I'll start her on clomiphene citrate or I'll start her on metformin lifestyle advice. No. The thing is with the biochemistry, 17-hydroxyprogesterone is elevated in what? In PCOS? Absolutely not. It is elevated in what? Non-classical, congenital, adrenal, hyperplasia. Okay, is a diagnosis of non-classical adrenal hyperplasia. That's why it's not PCOS. This is the reason I wanted to sit and work out MCQs with you all. That's why we will know where and all we are going wrong. We can correct ourselves. This is non-classical adrenal. He is 18 years of age. Right? Next question. 18-year-old student, again another 18-year-old student, admitted, fainted for the third time the past 6 months while at work. She tells you she feels tired, often suffers from muscle cramps. On examination, BP is 110, pulse is 67, her chest is clear, nothing is significant with a BMI of 22. The investigation shows low potassium, high bicarbonate, reduced urinary calcium. So what are the problems here? Low BP, slightly on the lower side, low potassium. Then what is up? Increased bicarbonate. Somebody feeling tired. We have discussed a similar question yesterday. Whoever attended yesterday's session or would have seen my core concept lecture will be able to answer immediately. What is it? What is it? And also reduced calcium. Addison's disease, really? Addison's disease, potassium will be what? Addison's disease, potassium will be high, doctor. Addison's potassium will not be low. Addison's potassium will be high. Addison's potassium will be high. Sodium will be low. See the sodium here. It says the sodium is low. No. So we have to be little careful when we are looking at the biochemistry. to avoid anything. Okay, you have to be little careful. So what is the answer? Is it Barter, Kahn, Gittelman, licorice poisoning, or Little syndrome? The answer is it's a Gittelman syndrome. Some of you clearly told it. Who told Gittelman? Dr. Taiba has told Gittelman. Some of you has told it's a Gittelman. So what is a Gittelman syndrome? What is happening? There is decreased BP will be there. Point number one. Second thing, low potassium, hypokalemia. Plus, increased bicarbonate signifies what ABG abnormality? Metabolic alkalosis. So hypokalemic metabolic alkalosis with decreased BP and decreased calcium is always Gittelman syndrome unless proven otherwise. Okay? Always Gittelman syndrome unless proven otherwise. Don't make any mistake in this, please. Okay? Little syndrome, potassium will be elevated with higher blood pressure. Barter mostly in the younger age. Kahn syndrome, again, high blood pressure. Licorice poisoning, there will be some clue like the patient is eating some Chinese herbal remedy or something like that. Now you review a 28-year-old woman who has been referred with amenorrhea. She's noted on a routine screening having raised prolactin level. She read about a condition on the internet, blah, 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 questions about prolactin. Thinking of hormones in general, which of the hormone is under continuous inhibition? Just now we have told. Which of the hormone is under continuous inhibition? Which of the hormone is given some security? Not allowed to go out. Continuous inhibition. It's prolactin. It's A, prolactin, doctor. It's not D. How many of you confused with D? No. If TSH is kept under continuous inhibition, everyone will have thyroid disorder. You and I, everyone will be in endocrine clinic. Only prolactin is kept under continuous inhibition. TSH is kept under negative feedback inhibition, not continuous inhibition. Okay. Next question. The answer is, the question is here. Leave everything up. They are asking which of the following would best differentiate between a pituitary adenoma and ectopic ACTH producing hypercortisolism. How do you differentiate between Cushing's disease and Cushing's syndrome? Or Cushing's disease and an ectopic Cushing syndrome? How? Low-dose DST, synactin test, 24-hour urinary cortisol collection, high-dose DST, basal ACTH level. What will help you to differentiate between a pituitary adenoma, that is a Cushing's disease, and the ACTH producing ectopic tumor? The answer is high dose DST. We have seen a exactly similar question yesterday. So most of you won't have any issues with that. Okay. Here, the question is simple. What antihypertensive medication should be started before surgery for a patient with pheochromocytoma? Again, pastors also had a similar question like this. What antihypertensive agent you will give before commencing a surgery on a patient with pheochromocytoma? It's always an alpha blocker, and the preferred alpha blocker, I told you, what is it? Phenoxybenzamine. Here, a 51-year-old white man was recently diagnosed with 2.5 centimeter papillary carcinoma of thyroid. No invasion, no lymphadenopathy, no metastasis, no history of head and neck irradiation, hoarseness, pain, dysphagia, or hemoptysis. Which of the following measure is most appropriate for the management? Here we have a person with PTC, papillary thyroid carcinoma. They are asking, he doesn't have any mets or capsular invasion, nothing. What is the appropriate management? You will do a partial thyroidectomy following radioactive iodine, or you will do a near total thyroidectomy following a radioactive iodine, or will you give thyroid hormone replacement, or you will give thyroidectomy, radioactive iodine, and thyroid replacement, or you will get even near total thyroidectomy with radioactive iodine and thyroid treatment. What will you do? Quickly, your answers before I start. Remember here, there is no capsular invasion, there is no distant metastasis. The answer is E. Okay. Papillary thyroid carcinoma is the most common type of thyroid cancer. So once you find a tumor, it can recur. Even though there is no metastasis, it can occur. The treatment of choice now followed in UK also the same thing, near total thyroidectomy with radioactive iodine. And of course, once you done a thyroidectomy, you have to give thyroid hormone treatment, replacement, hormone replacement therapy you have to give. All right. Don't forget papillary thyroidectomy, the treatment of choice is near total thyroidectomy with radioactive iodine and thyroid hormone replacement. All right. Next question. 71-year-old female resident of a nursing home. Her complaints are of poor appetite, weight loss, and cramps. 71-year-old female. She's diagnosed with Crohn's disease 10 years ago. She's not taking any medications. 5 months ago, she had mammogram and a flexible sigmoidoscopy. Both are normal. Because her examination was normal, she was given 1 month written appointment and sent for blood test. At the end of the day, what happens is her lab calls you urgently with a value of calcium of 1.4, low calcium, inorganic phosphate is 0.58, low phosphate, creatinine is 80, it's okay, albumin is low, alkaline phosphate is high. So a 71-year-old female, 71-year-old female with low calcium, low phosphate, high ALP. What are the things coming in your mind? Someone asked when to go for partial thyroidectomy. Typically, in compressive symptoms, you go for the doctor. And any toxic adenoma or anything, you go for a partial thyroidectomy. That is as per a medicine knowledge. Okay. To have a precise answer, surgeons will be able to have a better indications. What is happening here? Is it hypoparathyroidism, hypomagnesemia, vitamin D deficiency, kidney disease, or dietary calcium? It's not a kidney disease, I believe, because the creatinine is fine. The answer is vitamin D deficiency. She is on some form of osteomalacia, could be vitamin D deficiency because she's kept on nursing home. Sunlight exposure is obviously going to be poor in many of these cases. Next question. 38-year-old woman draws your attention for a swelling in the neck. She has noticed 2 days ago, no palpitation, diaphoresis, or weight loss, nothing is there. There is no pain also. And no hoarseness, nothing is there. The only medication she is taking is atenolol 50 milligram OD. But the blood pressure is 150 by 80. There is a 2 into 1 centimeter non-tender nodule on the right lobe of thyroid. No lymphadenopathy. Remaining of the examination is perfectly fine. What is the next investigation you will do? You are finding a solitary thyroid nodule. What you will find in a solitary thyroid nodule? What you will do for a solitary thyroid nodule? Only thing is an ultrasound. That's the next step to do. The next investigation is ultrasound. Last question is about a nursing home resident with decreased calcium, decreased phosphate, and normal creatinine levels and increased ALP. They asked what is the diagnosis. Most probably what happens in nursing home, the exposure to sunlight is poor. And also the diet will be poor in many of the patients. They will have dementia issues. They will have eating disorders, swallowing difficulties. So most likely causes a vitamin D deficiency. That's what we had discussed. Okay. Now, 72-year-old woman again comes with a chronic back pain, which worsened 1 week ago. She is a wheelchair bound. 6 months ago, she has severe osteoporosis, multiple lumbosacral spine fractures. She has severe rheumatoid arthritis for which she has to take a large dose of glucocorticoids for many years. Recently, she is also on omeprazole for severe reflux esophagitis. Her T-score is minus 3.5. She is not keen on very frequent, regular injectable therapy. What will you do? T-score minus 3.5 is a recognized case of osteoporosis. So here you are having a patient with osteoporosis with reflux esophagitis This patient is not interested in taking any injectable drug. What drug you will do? Give. Regularly, she don't want to get injected. Now these things and all won't help. You may not be able to give this that easily because she has reflex esophagitis. The only option is denosumab, that is a rank 1 ligand inhibitor used in the treatment of severe osteoporosis. Okay, you need not inject her regularly. Now, the next case, 35-year-old woman comes to see you with a history of cold intolerance, weakness, and constipation for 3 months. Her periods are regular but scanty. She has never been pregnant. His history is significant of hypertension, peptic ulcer disease. Her family history includes hypertension and diabetes. She takes ranitidine 150 milligram, sustained release nifedipine, and docusate sodium 100 milligram 3 times daily. Her pulse is 58, blood pressure is 135. She has Kangap reflexes. So all the things of hypothyroidism is there. Also, she has elevated CK, creatinine kinase. Free T4 is low, and free T4 is low, and TSH levels are less. Which of the following will most likely confirm her problem? Somebody with a hypothyroid picture, along with multiple family history of comorbidities, and she's having hunger reflex with a raised CK. What you will do? You will measure T3 levels. You will take an ultrasound scan. Will you take thyroid uptake scan? Will you take pituitary magnetic resonance imaging, or will you take anti-thyroid antibodies? What you will do? A, B, C, D, E. Thing you have to do is pituitary magnetic resonance imaging. Why? Yesterday we saw tertiary or central hyperthyroidism. What I said, there will be increased T3, increased T4, normal to increased TSH. Am I right? Whoever attended my yesterday's lecture would have listened to this. All of you clear? Now there is an entity called tertiary hypothyroidism. See this lady's biochemistry. What happens? T4 is low. When T4 is low, what should happen to TSH? When T4 is low, what should happen to TSH, doctors? Come on, answer me. When T4 is low, what should happen to TSH? Hi, what is happening here? What is happening here? It is high or low here. See the question. Then you will never forget when this question comes up, when such scenario comes up in your exam. It is what is happening here. TSH is low. TSH is also low. And what happens to T4? We don't know. So this points a tertiary level, a central level hypothyroidism. Again, like tertiary hyperparathyroidism. All will be low, all will be up. Or the TSH will be normal, paradoxically. So you have to take a pituitary magnetic resonance image. All right. Next question. 38-year-old woman comes to you for a repeat prescription. She had hypertension since her last pregnancy. At the age 30, she maintained on clonidine 0.2 milligram twice daily. She gets headache, dyspnea on exertion, swelling of her feet, orthopnea, but denies chest pain. Her father is also treated for hypertension. She does not smoke. She's 5'7" tall and weighs 15 stone. Blood pressure is 180 by 110 and pulse is 92 beats per minute. The rest of her examination is remarkable for hypertensive retinopathy, bibasal rails, 1 plus pitting edema. Initial lab results were normal except for potassium low and the serum bicarbonate is high. Correct the hypokalemia and random aldosterone level is 25. Plasma renin activity is 0.5. That is low. What is the additional test you are going to do here? What is the additional test you can do here? Somebody coming with to you for a repeat prescription. Okay, somebody is coming with you for a repeat prescription. Clonidine is 0.2 milligram given here. Okay, blood pressure is 180 by 110. Hypertensive retinopathy, everything is set in. Potassium is low, bicarbonate is high. So you suspect con, what you will do next? You'll do saline loading, 18-hydroxycortisone, adrenal vein sampling, adrenal CT with adrenal vein sampling with 18-hydroxycortisone. Answer is 3. You have to do all the 3 things. Suspect cons, you have to do all the 3 things because he already measured renin aldosterone activity. CK levels in last question, somebody asked a doubt. Sometimes it can go up and down in hypothyroidism. Sometimes, especially in tertiary hypothyroidism. Or it can be non-specific as well. Okay, non-specific as well. Next question. Previously fit 30-year-old man presents with 2-month history of weight loss, tiredness and nausea. 30-year-old guy who is previously fit. No past medical history. Examination reveals blood pressure of 110/70, pulse is 78 beats per minute, and a postural drop is there with low sodium and high potassium. I won't go beyond anything. You should be able to tell the diagnosis. TSH is also high with low normal T4. What is the diagnosis here? High potassium, low sodium, postural drop, weight loss, nausea and vomiting, decreased BP. Tells you what makes you think long. There is not a lot to think here, right? Straightforward thing. So what you will do here? What test you have to do? You do your short snack test. 17-year-old girl again, now an Addison's disease case, is intolerant of hydrocortisone, which she takes at a dose of 20 milligram in the morning and 5 milligram in the evening. Which of the following doses of prednisolone would provide approximately equivalent dose of the hydrocortisone? You should know something called steroid equivalent. How many of you know steroid equivalents? How many of you know steroid equivalents? How many of you know steroid equivalents? I will teach you, don't worry. You give how much prednisolone? 1 milligram, 6.5 milligram, 10 milligram, 12.5 or 15. Okay. No problem. I'll tell you. Note it down. Hydrocortisone, prednisolone, methyl prednisolone, triamcinolone, beta-methasone, dexamethasone. 20 milligram of hydrocortisone is equal to 5 milligram of prednisolone is equal to 4 milligram of methyl prednisolone is equal to 4 milligram of triamcinolone is equal to around 0.75 milligram of dexa. This is just out of my memory. I'm just telling you. Okay. All of you noted it down very carefully. Just remember this. Now go back. She is taking 20 milligram of hydrocortisone. She was taking and 5 milligram in the evening. Okay. She's telling 20 milligram hydrocortisone. When 20 milligram hydrocortisone in the morning and 5 milligram in the evening. Hydrocortisone. What is the dose equivalent of prednisolone here? Calculation. Who's smart in mathematics? Calculate and tell me. Others? Anyone else? I want you, all of you to clearly understand, calculate and tell. The answer is 6.5 milligram. Okay, 6.5 milligram. But in an ideal clinical setting, the answer is going to be 10 milligram. But why it is 6.5 milligram is the dose is divided into 2. I will tell you. Okay, the dose is divided into 2. She is taking 20 milligram in morning and 5 milligram in the evening. Prednisolone is potent than hydrocortisone. Your answer B is right if I directly ask the dose. Okay. Your answer B is correct if I directly ask the dose. What is the equivalent? What you have done, you guys calculated the equivalent dose and told it's 10 milligram. Okay, this is the equivalence. But what is the dose that is required for her is 6.5 milligram. Why it is? Equivalent dose is obviously 20 milligram of hydrocortisone equal to 5 milligram of prednisolone, no doubt. But what happens? Usually about steroid, when you're going to give steroid dose, when you're going to give transfer from hydrocortisone to prednisolone, typically you give just about 1/3 only, or around 25% of the dose only you will be giving. Okay, so it is somewhere close to 25 milligram or 6.5 milligram. That is the answer. The answer is dose equivalent, doctor. Please read the question when I'm doing, because I cannot keep on coming back and repeating all the questions. We have huge number of questions to work out. Okay, please read the question carefully. This is a MCQ workout session. I have to be quick. So the dose you have to give is 6.5, but all of you got it right. You got it 10 milligram. That is the equivalence. They are not asking here the equivalent. What is the dose you will provide her? If they ask you equivalent, this is the formula. 10 milligram is correct. But if they ask the dose you will provide, when it comes to transition from hydrocortisone to prednisolone, you give somewhere around 25% of the dose or 1/5 of the dose, that is equivalent to 5 milligram. Okay, that is equivalent to 5 milligram because of the increased potency. Now, 40-year-old woman prescribed thyroid replacement therapy. She has routine thyroid function test, which is currently well. On medication, apart from thyroid hormone, she has a stable fate. What is a TFT? TSH is normal. Free T4 is low. Free T3 is normal. Okay, her T4 is low. TSH is normal. T3 is also normal. So what is the correct statement? A thyroid hormone replacement is adequate. Or does she need an investigation of pituitary function? Or she has tertiary hypothyroidism? Or she has subacute hypothyroiditis? Or she has sick euthyroid syndrome? Now all of you, any one of you, please answer according to your expertise what this could be. What is happening here in this lady? What is happening here in this lady? Again, see here, her T4 is low, TSH and T3 is normal. What this could be? Her T4 is low, TSH and T3 is normal. The answer is her thyroid hormone replacement is adequate. Okay, thyroid hormone replacement is adequate. This is some notorious person from past test has taken this, past medicine has done the question. I'll tell you. In subacute hypothyroidism, there will be some clinical finding will be there. Okay. Here, the main thing you have to take into account is a T4 and not a T3 when you come to monitoring a patient with a thyroid disorder. Okay. Monitor, and she is also clinically euthyroid with a normal TSH range, and T4 if it is particularly low, and with T3 in the normal range and TSH also in the normal range, mostly her replacement is adequate. Okay, mostly her replacement is adequate. Next question. A diagnosis of diabetes mellitus was considered in a 32-year-old South Asian woman who is 16 weeks pregnant. Her body mass index is 22, 75 gram OGTT was reported as follows. Okay, her OGTT glucose is high. Fasting glucose is little high. After 2 weeks of dietary modification, fasting glucose is still 0.8. What is the approximate next step in management? See clearly. Next, I'm going to change the slide. 32-year-old South Asian woman. She's 16 weeks pregnant. Remember, she's a pregnant woman. Her OGTT values are fasting 6.9, postprandial 12.5. 2 weeks, she is asked to take dietary modification. Still, her fasting glucose is 6.8. What will you do here? Low calorie diet, soluble insulin, glipizide, metformin, or repeat OGTTD in 4 weeks? The answer is metformin. Yesterday, we have seen a similar question. Okay. Now, 33-year-old woman with a history of bipolar affective disorder who is taking lithium presence to the clinic. She has met a new partner and wishes to lose weight and become pregnant. Her body mass index is 35. TSH is high. Free T4 is low. Prolactin is 800. And pelvis shows polycystic ovaries. So they have given you the diagnosis of polycystic ovarian syndrome, which is significant by associated hypothyroidism and increased prolactin. So what is the best initial management for her? Will you give a dopamine agonist? Or will you give her thyroxine? Or will you give stop lithium and replace with lamotrigine? Or will you give metformin? Or will you give thyroxine and dopamine agonist? What is the best initial management? Next, C, C, and E. E, dopamine agonist for what here, doctor? Why would you give a dopamine agonist here? Any indication? For this prolactin, we don't give dopamine agonist. We know the prolactin is high. Dopamine is an antagonizing hormone. For this prolactin level, you don't give that. Because prolactin will be high in PCOS. We don't treat her prolactin levels. We treat the underlying condition. All right? Just remember that. So first thing is to stop lithium and replace with lamotrigine. Why? This is a teratogenic drug. Her lithium level should go down first. That's my very first concern. Then I will treat her PCOS. Her thyroxine level is not my concern because what is her major concern? Her major concern is she wants to lose weight and become pregnant. So two things I need to do. I need to make sure her pregnancy doesn't get even full pregnancy or the fetus doesn't get teratogenic toxicities or anything. So I need to stop lithium and replace with lamotrigine. That's the first best thing I have to do. Next comes everything. All right. Next question. 72-year-old woman referred to general medical clinic with a weight loss of 6 kg. She admits being lethargic and off her food. Her blood pressure is 122. There is a postural drop on standing. Investigation show low T3, low T4, low TSH. Sodium is also low. What is the diagnosis? Low T3, low T4, low TSH, low sodium. What things are coming into your mind or what things are ringing in your mind seeing this particular finding? This could be a tertiary. Okay, this could be a tertiary. But sodium is also low. Am I right? Sodium is also low. So along with thyroid, something else is there, right? She's lethargic. And there is a postural drop is also there. So along with hypothyroidism, something else is there. This is an anterior hypopituitarism. Okay, of course, it's a tertiary hypoparathyroidism. Along with thyroid, there is something else is there, that is pituitary levels are low. The question here is simple. Here, a 23-year-old lady comes with oral ulcer, anorexia, weight loss. She's 21-year-old. She had a history of thyroidectomy for autoimmune thyroid disease. Now they're asking which of the following would suggest polyglandular syndrome type 1. Okay, there is a table in my core concept lecture. All of you can go ahead and see the table and see which disease is associated with APS1 and APS2. It's very tough to remember, but I gave you some clues. I told you which particular diseases you guys have to remember in that. All right, which signifies APS1? Anyone? Which of the following you will see in APS1? Celiac disease, type 2 diabetes mellitus, hypocalcemia, hypercalcemia, diabetes insipidus. Come on, try. Okay, answer is hypocalcemia. X. Fantastic. Good. Hypocalcemia seen in APS1. For the rest of the things, please go and see the table. Okay. Now, 54-year obese woman has been referred because of poor diabetic control. Despite being on glycoside 160 milligram twice daily, she has a history of hypertension that is managed with ramipril 10 milligram indapamide. Her BMI is 35. There is also a history of irritable bowel syndrome. Biochemistry shows mild increase in urea and creatinine is up. Alanine and GGT both are normal. HbA1c is high. What will you do next in this patient? Poor diabetic control. She is obese. There is a poor diabetic control. She is obese. Raised creatinine is there. Mildly raised urea is there. ALT and GGT both are normal. What is the next thing you will do? You add acarbose, you add dulaglutide, you add pioglitazone, you add metformin, or you switch to repaglinide. What will you do? The answer is D, dulaglutide. Why you add that? She is already obese. She started developing complications. Best bet would be a dulaglutide. 23-year-old patient being investigated for polydipsia. There has been no recent loss of weight. She takes no regular medications. Investigation shows sodium, potassium, only polydipsia. Okay. What is the likely diagnosis? Only polydipsia, nothing else. Is it nephrogenic diabetes insipidus? You will find something. SAADH, you will find something. Cranial DI, you will find something. Is it psychogenic polydipsia or water intoxication? Answer is psychogenic polydipsia. I told you what happens when somebody intoxicates themselves excess with water. What will happen? I told you about Chinese water torture also. They do it actually to kill people. Waterboarding, if you take anybody, push water throughout in his mouth through a tube, he will die after some time. I told you the mechanism also. Right, now comes another big question from past medicine. 27-year-old woman admitted 2 days ago through the emergency department with complaints of seizures. She uses moderate alcohol. 2 weeks ago, she received penicillin for secondary syphilis. She's complaining of muscle cramps, weakness, and headache. She received 1 gram of phenytoin on the day of admission, now taking 100 milligram 3 times daily. She is also taking paracetamols, multivitamin, and tapering dose of chlordiazepoxide. There is a history of seizures in her family. She is 152 centimeter tall and weighs 55 kg. Blood pressure is 130 by 80. The rest of the physical examination is normal, apart from a round face, short neck, short fourth and fifth metacarpals, and bilateral cataracts. Calcium is low, phosphate is high, intact parathyroid hormone. What is the diagnosis? What is the diagnosis here? Somebody is having a seizure. We saw yesterday somebody is thin, round face, short neck, short fourth and fifth metacarpals, cataracts, normal PTH but low calcium and low phosphate. Low calcium, low phosphate. Round face, short fourth and fifth metacarpals with bilateral cataract. No, not Cushing's. You don't get cataracts and short fourth and fifth metacarpals in Cushing's. I told you all of you to go and see the video in my core concept lecture where a patient with a similar condition has been taken and the doctor clearly shown all the face, including his face, his teeth, his metacarpals. This is nothing other than your pseudo hypoparathyroidism. We had discussed yesterday. Last question, somebody has a doubt. Last question is nothing. Somebody is having drinking excess of water with no biochemical abnormality. Only diagnosis is psychogenic polydipsia. Because if it is diabetes insipidus, osmolality will change, sodium levels will change. If it is water intoxication, definitely there will be changes. So only water is drinking water in excess, psychogenic polydipsia. Then you review a 52-year-old woman in thyroid clinic, and she has a thyroid mass. Her functional status is excellent, no significant previous illness. She currently holds down a partial job, part-time job as a solicitor. Biochemical received shows normal thyroid function. FNAC reveals thyroid lymphoma. Which of the following is the choice of therapy? What do you do for a thyroid lymphoma? Suppressive treatment, radioiodine treatment, chemotherapy, external beam radiotherapy, or palliative? You give radiation for lymphoma? The answer is yes. You give chemo and external beam radiation, not just the radiation. You have to first start with the chemotherapy, and then you have to give external beam radiation. This is the treatment of choice for thyroid lymphoma. Last question, somebody has a issues with why it is not a pseudo Cushing's. Why on earth pseudo Cushing people will have a short metacarpals? They may have round face. And why they will have a biochemical abnormality of decreased phosphate and decreased calcium? They won't. They won't. That itself is clinches and takes you to pseudo hypoparathyroidism. 40-year-old woman complains of feeling tired all the time. The lab results are cholesterol 6.8, HDL is low, thyroglobulin is 2.2, free T3 is 10, TSH 2.5. What's the most appropriate treatment for patients lipid abnormality? So what is happening here? TSH is high. So what is she is having? Hypothyroidism. She is having hypothyroidism plus increased cholesterol. What do you treat? You are seeing this patient in your OPD. Doctors, what medication you will prescribe for her? What medication we will prescribe for her? Only thing you have to do is thyroid hormone replacement. Because yesterday I said all the people with hypothyroidism will have some lipid abnormality. You have to treat the thyroid disorder. You have to replace the thyroid hormone. Like I said, PCOS will have increased prolactin. What you have to treat? You have to treat the PCOS, not the increased prolactin. Next question. A driver with a history of type 2 diabetes has been changed from oral medication to insulin. He wishes to begin driving group 2 vehicles. What does he needs to prove so that he can drive a lorry? Someone with a type 2 diabetes mellitus changed from oral medication to insulin. He wants to drive group 2 vehicles. What will you do? He can drive, or he must wait for 3 months. He must wait for 6 months. He must wait 1 year, or he needs to confirm he has no episode of severe hypoglycemia in the last 12 months. I have a separate lecture on DVLA regulations. You can watch MedXM expert subscribers. You can watch separate lecture only on DVLA. We had the answer is he should at least wait for 12 months. Group 2 is a heavy vehicle. He cannot be just like that allowed to wait for 3 months. And he needs to check his blood glucose continuously. He needs to make sure he doesn't have an episode of hypoglycemia. Otherwise, he will put himself and put everyone else who is traveling with him at a risk of accident. You don't want that to happen. And you don't want to be the culprit doctor who let him to drive in 6 months, 3 months, or in few weeks. He should wait for 12 months, but need to confirm no episodes of severe hypoglycemia. 56-year-old man with a history of type 2 diabetes and has an anterior MI 5 years ago. He is receiving aspirin 150 milligram and twice daily insulin. BMI is 34, HbA1c 6.9. Okay. Cholesterol is 3.6. Which of the following measures would delay in deterioration of renal function? So what they are asking, he is a diabetic guy, his BMI is high, his BP is high. Okay. Cholesterol levels are however normal. they want to offer some renoprotection. So what will you give? Will you give orlistat to reduce weight? Will you increase the insulin frequency? Or will you give ramipril? Will you give simvastatin? Will you give aspirin? The answer is very famous answer, ramipril, AC inhibitor. Next question. 26-year-old man with Addison's disease. 26-year-old man holds Addison's disease with acute onset diarrhea and vomiting for past 6 hours. Apparently, his two children recently has been ill with 48 hours vomiting. See, somebody wrote vomiting virus. What is a vomiting virus? God alone knows. The problem with past medicine is that, I'm not blaming past medicine people. These past medicine questions are not written by qualified personnel. Anyone who randomly pass MRCP 1 can go and write past medicine. Past medicine. Like some gentlemen here in India are charging 1 lakh, 3 lakhs for PACES course and MRCP part 1 course to teach them who never sat for any MRCP 1 exam in their life. People are ready to believe all they do is a good promotion. They are ready to believe and give the money. He currently takes fludrocortisone and hydrocortisone. This is the problem with past medicine questions. That's why I always suggest past test first and past medicine. Okay. So here, this is the thing going on in an Addison's patient. So what will you do here? What will you do? You give IV cyclicin or you give IV ondansetron. What will you give, doctor? What will you give? What will you give? Course intravenous fluids and hydrocortisone. 65-year-old, somebody asked doubt on ambulance. Ambulance, you need to have C1 level qualification. Group 2 and slightly higher up ambulance and fire service. So do the police drivers because they have to chase, right? Ambulance has to chase against time. Police has to chase against thief or anyone, any antisocial element. And fire service people has to chase against time to save people. So they need higher quality. C1 level they need. 65-year-old woman with type 2 diabetes mellitus has 2 episodes of dizziness associated with driving a car. She currently administers insulin. Her glucose is 2.1, which improved after intravenous glucose. Her insulin dose was reduced. On further questioning, she admits to one collapse after she later come around the kitchen floor. So someone with type 2 diabetes developing dizziness associated with driving a car, she administering insulin and she becomes hypoglycemic. What is the next step you will do? Logically, you'll give an MRI of brain, you will do a 72-hour hospital administration, you will advise not to drive, psychiatry referral, better diabetes education. The answer is advise not to drive. The first thing, she's a 65-year-old lady. There are nothing significant of an insulinoma or nothing here that says she's doing insulin abuse. So you don't need to measure all those things here. She's a 65-year-old poor old lady. The only concern you need to do is she is not supposed to drive. She will put herself and put everybody else in danger. So the very first advice is not to drive. Then you should ask whom she is living with and you should advise them to have a better control on her. 24-year-old woman is referred to GP. She's 10 weeks pregnant, complaining of anxiety and inability to sleep. Total thyroxine level is 160. T3 is 160. T4 is 27. TSH is 0.2. What is the management of choice? In pregnancy, commence low dose carbimazole. What is a week? 10 weeks. Commence profile thiazole. You will observe or start high dose carbimazole and thyroxine block and replace or measure anti-thyroid antibody level. Remember, this is pregnancy. She's 10 weeks. Okay. What will you do? The answer is C. You just observe and repeat. You commence profile thiouracil, just note it down. You commence profile thiouracil in pregnancy only if patient is symptomatic or grossly altered biochemistry. Just by seeing some slight alteration in thyroid hormone level, which could be due to pregnancy-induced changes, which we described yesterday, which we had discussed yesterday, you please don't do anything, don't mark any such option. You have to observe and repeat the test after 1 month. 35-year-old woman referred by GP to the hospital because of recurrent episodic headaches, which tends to come on at times at the stress of exercise. She's headaches coming at the time of exercise. Yes, she also complains of intermittent anxiety, palpitation, and sweating. Okay. Now, 24-hour urinary catecholamine shows raised normetanephrine and metanephrine. There is a mass in adrenal. What is the definite management plan? So somebody is here with pheochromocytoma. That is obvious with a question. They are asking, what do you do? You will do beta blockade, then do adrenalectomy, or you will do adrenalectomy, or you will do alpha blockade, then beta blockade, then if required, unilateral adrenalectomy, or will you do beta blockade, then alpha blockade, and do unilateral adrenalectomy? Then, or you will do both and do. She has mass in the right adrenal medulla only. Remember, she has pheo on right side only. Now tell me, what do you do? What do you do? Yes, the answer is C. First, and if needed, unilateral adrenalectomy. You don't do an adrenal, you never, ever do a bilateral adrenalectomy. It will lead to adrenal crisis. Okay, adrenal crisis. Urgent beta blockade, then unilateral adrenalectomy, you don't do. Option A is wrong. You don't give beta blocker in pheochromocytoma first. What you will give? You give alpha blocker, then followed by beta blocker. This concept has been asked so many times, we have discussed. Next question, 25-year-old woman present with a small lump on left side of the neck. It has been present for several months. She has noticed changing in size. Thyroid function test, ultrasound classified as a U4 nodule and FNAC revised THY5 architecture suspicious of carcinoma of thyroid. She undergoes hemithyroidectomy, which reveals 1.5 centimeter papillary thyroid carcinoma with a good margin clearance. No extra thyroidal extension, nothing. Now, after this papillary thyroid carcinoma, hemithyroidectomy, what you will do? You will give thyroxine replacement and radioiodine, or you will observe, or you will do total thyroidectomy, or you will give total thyroidectomy, radioiodine, and oral replacement, or radioiodine therapy. The answer is observation, because everything is done for her. Only thing is you should observe, because there is no lymph node, no extra thyroidal thing. Okay. Okay, you guys want a prayer break? Well and good. Only this question we will finish and we'll give a break. Okay. 58-year-old woman presents with fever, palpitation, muscle weakness, sweating, and diarrhea. Examination reveals a small goiter. ECG shows fast atrial fibrillation with a ventricular rate of 135 beats per minute. Blood tests reveal an elevated WCC and CRP. TSH is low. So what is the diagnosis here? Systemic infection, hypothyroidism, pheochromocytoma, thyroid storm. See here, fast ventricular palpitation. What is it? This is a thyroid storm. We had extensive discussion on the management of thyroid storm in our lectures, okay? In our core concept lectures. All right, guys, we will take a 10 minutes break. We will come back and we will do more questions, okay? Let's take a 10 minutes break right now, all right? See you guys. Take care. Good evening, everyone. How many of you are here? Just say hello, hi, something in the group so that we can begin the discussion right away. Yes. Thank you, doctors. Yes, we'll start it shortly. Okay. Let's begin. Just let me connect my tablet. Yes. Oh yeah, here we go. Now, yep. Okay, 34-year-old woman with Graves' disease has been treated with radioiodine. What is the best advice for patient during the post-radioiodine period? Say for her to try and conceive after 3 months. She should not have close contact with the young children and pregnant women for 10 days. There is no need to monitor her TSH. She will never need further dose of radioiodine. She can be in close contact with children within 1 day. Which of the following statement is correct? Have doubt? Listen to my core concept lecture. I had clearly explained that about everything. Clearly explained that. What is the answer? The answer is yes, B. Okay, she should not have close contact with young children and pregnant women for about 10 days. Okay, the answer is B. 61-year-old patient, the history of recent thyrotoxicosis, underwent major surgery 1 week ago. Now she presents with altered mental status, tachycardia, high-grade fever, vomiting, and a diagnosis of thyroid storm is made. So they gave the diagnosis in thyroid storm. Transfer to ITU, avoid using chlorpromazine, avoid carbimazole, potassium iodide should be given with propylthiouracil. Peritoneal dialysis you're going to start. What you will do? What is the next step? What is the next step is transferring the patient to ITU. Okay, this they are just checking your knowledge on how you handle a patient in real life. So somebody is coming with a thyroid storm, things are getting worse. The next step, the next immediate thing you have to do is transfer the patient to the intensive care unit. All right. Next question. 25-year-old woman develops hyperthyroidism 6 weeks after delivery. On examination, she has painless, firm enlargement of the thyroid gland. TSH receptor antibody testing is negative. Okay, what is the probable diagnosis? Hypothyroidism post-pregnancy, post-delivery, mostly postpartum hyperthyroidism. Postpartum thyroiditis. All of you agree with that? Yes. Now, okay, postpartum thyroiditis. Now, the condition is more likely to in the one who with TPO. Is it correct? Most patients will have lifelong hypothyroidism. Is it correct? It's less common in patients with a history of type 1 diabetes. Is it correct? Around 20% of women have some degree of thyroid dysfunction postpartum. Is it correct? Or if it is associated with intense fibrosis of the thyroid gland, what is the correct answer? They're asking about postpartum thyroiditis. They're given the diagnosis. The patient is pregnant. Post-pregnancy, she's having hypothyroidism. So what is the right diagnosis here, doctors? Anybody? Any clues? D. The answer is A. Okay. Answer is A. There is a study that actually shows TPO positive people are more likely to get postpartum thyroiditis, PPT. Most patients will have lifelong hypothyroidism. Absolutely not. It's less common in a history of type 1 diabetes. It's more common actually. On the contrary, with people, around 20% of women have some degree of thyroid dysfunction postpartum. The number is wrong. It's not 20%. Yes, some amount, but it's not 20%. If it is associated with intense fibrosis, no. That would be fibrosis is not in the postpartum thyroiditis. 24-year-old woman presents with 13 months of amenorrhea. For the past few months, she has been experiencing hot flushes, night sweats, mood changes, and pain during intercourse. Clinical examination is unremarkable. Her FSH is more than 40 on 2 separate occasions. Her serum estradiol level is 45. Testosterone is 1. TSH level is normal. Fasting glucose is normal. Pregnancy test is negative. What is a likely diagnosis? C. 13 months of amenorrhea, 24 years of age. Hot flushes, night sweats, premature ovarian failure, polycystic ovarian, androgen, pituitary failure, hypothalamic amenorrhea. See her. FSH is also high. Right, it's high on 2 occasions. The diagnosis is a premature ovarian failure. Right? Persistently high is FSH with low estrogen. Most common cause is COPOF. 44-year-old woman has attended the emergency department for a number of occasions this year for renal tract stones. She has suffered depression during the last year. She's found to have serum calcium of 3.10 and an albumin of 40, the creatinine of 130. She has previously been successfully treated for cabergoline for prolactinoma. What is the underlying diagnosis? Prolactinoma, so pituitary tumor. Increased calcium could be due to increased PTH. What's the diagnosis? Come on, how many times we can see the question? So many times we had focused on similar things. What is it? What is it? Pituitary, increased calcium. What is it? It's obviously your good old Men-1 syndrome. Good old Men-1 syndrome. 40-year-old man having routine blood test completed as a part of pre-employment screening. He is well with no complaints. He is noted to have serum calcium concentration of 2.85. That is high. Normal phosphate, urea, vitamin D, PTH level, urinary calcium excretion is 12 milligram. Okay, which is kind of low. No history of renal stone or pancreatitis, depression, nothing. He is referred to endocrine surgeon for a consideration of parathyroidectomy. As renal stone, hypercalcemia, he wants to go for parathyroidectomy. What is the right thing? Surgery is appropriate treatment. Yes or no? Or is it unusual he does not have symptoms of hypercalcemia? Inheritance of this condition is autosomal dominant. Acute pancreatitis is commonly associated with this condition. Or his calcium receptors have increased ability to sense raised calcium level. What is this? What is happening here? Somebody's calcium concentration is high, but in his urine, the calcium concentration is low. So what you are dealing with, he wants to do a parathyroidectomy. Do you go ahead and do the surgery? What is this? This is a FHH. Excellent, Dr. Tayaba. This is FHH. Many of you know familial hypercalcemic, hypocalciuric, hypercalcemia, or hypercalcemic, hypocalcemia. This is a potentially life-threatening condition. Okay. However, FFH is rare, lifelong benign condition. Hypercalcemia is life-threatening condition, but FHH is a benign one because calcium only excretion will be low. Hypercalcemia can lead to renal stones formation. The inheritance is autosomal dominant. So it's the C is the answer. Surgery, will you do for this? No, because parathyroid has nothing to do with it. Calcium receptors have increased ability to sense raised calcium level. No, rather quite the opposite. It has decreased. Acute pancreatitis, no, it's not associated with it. It's unusual. He does not have any symptoms of hypercalcemia. Yes, familial FHH, the patient may not have typical symptoms of your hypercalcemia. Okay. 26-year-old woman with a 10-year history of well-controlled type 1 diabetes. She's treated with insulin pump, now presented for her routine diabetes appointment. She has been talking to a patient in the waiting room on dialysis for diabetic nephropathy that she has number of questions regarding a risk of renal disease. Which of the following statement best describe renal disease in a patient with type 1 diabetes? The question is simple. Which of the following best describes renal disease in a patient with type 1 diabetes? A microalbuminuria usually occur within 2 years. Or diabetes is the number one cause of end-stage renal disease in Europe and US. Serum creatinine 200 reaches 200. With a fall in GFR of 0.5 millimeter. CKD usually occurs within 5 years on the onset of albuminuria. Or people with overt diabetic nephropathy have a 10 times higher mortality rate. What is the answer? The answer is B. You don't worry about anything, but just remember, diabetes is the number one cause of ESRD in Europe, especially in UK. None of the things are true. Next question. A 70-year-old man is brought unconscious to the emergency department. His blood sugar level is found to be 50 millimole. He is a smoker. But his GP's letter state he is a recluse, has not attended any medical review. His ABG reveals hypoxia. He is normal pH. He has 1 plus urinary ketone. Okay. Evidence revealed left-sided lung consolidation. What is the underlying cause of rise to glucose? What is the diagnosis? Someone has a left-sided consolidation, 1 plus ketone. Hypoxia is there. But surprisingly, normal pH and bicarbonate is there. Blood glucose is 50 millimole. He is 70 years old. Can somebody correlate this and come to a conclusion what we are facing with? What we are facing with, doctors? 70-year-old guy, blood glucose of 50 millimole. There is hypoxia, 1 plus ketone. This guy is a recluse. There is evidence of left-sided lung consolidation. What is the diagnosis here? Come on, just think and try. Try and tell some diagnosis. Anybody, come on. Don't hesitate to answer. Think. Put your thinking hats on. Is it sepsis, type 1 diabetes, type 2 diabetes, steroid diabetes, glucagonoma? What is it? The answer is type 2 diabetes, because this answer, the diagnosis, hyperglycemic hyperosmolar coma, okay, or hypoglycemic hyperosmolar state. How? Because the guy is 70 years. Mostly it is common in elderly. High glucose levels. Ketones can be seen. 1 plus ketone is okay. And also what else that signifies is normal pH and normal bicarb. All this pointing towards hyperglycemic hyperosmolar coma seen in type 2 diabetes. A highly insulin resistant 56-year-old man with a type 2 diabetes has been taking 200 units of subcutaneous insulin per day. His weight is increasing and his control is worsening with HbA1c of 9.1%. He wishes to discuss adding pioglitazone to his regimen. He has read that it may help reduce insulin requirement. Which of the following statement best describe pioglitazone? So they are testing our knowledge on pioglitazone. Does it cause heart failure by direct toxicity in the myocardium? Or does it associated with weight loss? Does it have no mineral effect on bone mineral density? Or heart failure can be precipitated by patients with glitazones due to fluid retention? Or does it act on paroxysmal proliferative gamma receptor alpha? What is the diagnosis? How pioglitazone causes heart failure? I told you. Yesterday we had discussed. The answer is D. This pioglitazone, what it causes increased retention of H2O and as well as sodium. This will lead to heart failure. It doesn't have direct toxic effect. It is associated with weight loss. Some drug that is causing increased retention of water and sodium will cause weight loss or weight gain. It will rather cause weight gain. So that is not the answer. It has no effect of bone mineral density. No. Answer is D. It acts on the receptor gamma, not on alpha. 17-year-old girl presents to the ED with a history of the blood glucose of 29. She's known to have type 1 diabetes. Her pH is 7.2. She has 4 plus ketones. So the diagnosis of DKA is made. Now they are asking which of the following statements about the DKA is true. Myocardial infarction is a precipitating factor in up to 5%. Infection is precipitating factor in 70%. Bicarbonate levels can be normal. Blood glucose can be normal in DKA. Non-compliance with insulin causes 5% of cases of DKA, which is the right answer. Anybody? Any more answers? Come on, in a quick succession. The answer is going to be little surprising. Answer is D. I'll tell you why. MI is not a precipitating factor up to 5%. The numbers are wrong. Infection is not always. Infection rate is, I think, somewhere around 40 something. It's not the 70% cause. Otherwise, every diabetic whoever getting infected will be a DKA. The main cause is dehydration than infection. Okay, it's dehydration. Bicarbonate levels can be normal in DKA. No, it's one of the criteria. Non-compliance with insulin. No, then everyone with insulin will be in a DKA because most people who are taking insulin are non-compliant only. They're taking insulin whenever they want. They are adding sugars to their food, living erratic lifestyle. Without knowing, diabetes is something that can be completely stopped and patient can live a normal life and healthy life like everyone else if they control their tongue. Blood glucose can be normal in DKA. Yes. Why? It is called euglycemic DKA. It is seen especially when someone taking SGLT2 inhibitors. Okay. High dose SGLT2 inhibitors can cause euglycemic DKA. All right. That's the answer. 36-year-old woman who is 18 weeks pregnant attends midwife clinic for pregnancy check. She is noted to have glycosuria. She has a BMI of 30 kg, PCOS. We suspect her mother has type 2 diabetes. What is the current management plan for a diabetes in an 18-week-old pregnancy? Wait until 24 to 48 weeks gestation. Commence insulin. Perform 75-gram oral GTT. Perform fasting blood glucose. Perform HbA1c. What you will do? Pregnancy, it's always you have to do oral glucose tolerance test. That is the right answer. In a pregnant woman, you are suspecting diabetes. That is the next best thing to do. Next thing, a 75-year-old woman is brought to the emergency department via ambulance in a completely unconscious state. Her doctor found her on floor. On examination, she is found to have a core blood body temperature of 33, hypothermia, BP and pulse is low. Through examination reveals congestive signs of congestive cardiac failure. A glucose is 5. Random cortisol is 450. Routine ABG is normal. However, a TSH is 43. T3 is of 0.8. What is the diagnosis? What is the diagnosis? Think little, you will get the diagnosis. Think little, you will get the diagnosis. I want you to all have to think a lot and type faster so that we can cover everything which we intended to cover. Okay. Somebody is knocked out on floor, doctors. Next, what has happened? Her pulse is low. She is having severe hypothyroidism. What will happen in this? Somebody knocked on floor, low pulse, severe hypothyroidism. What is this? This is your good old mixed edema coma. What is there to think a lot? Hypothyroidism. She is knocked out on floor, severe bradycardia, hypothermia. All are features of what? Mixed edema coma. 62-year-old woman undergoes subtotal thyroidectomy for goiter. 12 hours after the operation, she calls the duty doctor, found to be suffering from pins and needles in her hands and a carpopedal spasm. Urgently corrected calcium level is found to be 1.95. She has hypocalcemia post subtotal thyroidectomy because the surgeon would have nicked the parathyroid gland as well. It happens commonly. It's okay. So they are asking what is the true statement regarding this patient. She is likely to have permanent hypothyroidism, hypoparathyroidism. Her hypocalcemia is likely to be transient due to local trauma. Her hypocalcemia is likely to be related to acute fall in active thyroid hormone after thyroid gland removal. Her measured PTH at this time will be high. Her hypocalcemia is predominantly due to coexisting deficiency. What is the right answer? 10 to 15 seconds you take and give me the answer. The answer is B. Just now I told you, in case of thyroid surgeries, many people accidentally nick, so they will be having transient hypocalcemia. All the symptoms will be there. You just have to replace the calcium. They will be fine. Now you review a 32-year-old woman with relapsed Graves' disease. A thyroid stimulating T3 of 52.5. Bilateral proptosis is there. Thyroid eye disease is there with marked orbital edema, proptosis. She is also a smoker. You are considering definitive treatment. So they are asking what is the most accurate statement regarding management of thyroid eye disease. Systemic steroids are of no value. You will go for a subtotal thyroidectomy. Stopping smoking will make no difference. Absolutely not. Radioiodine treatment will you give? You don't give. Total thyroidectomy is the best treatment of option. What will you do for thyroid eye disease? Which is the correct statement? Which is the correct statement regarding thyroid eye disease? D. Radioiodine. Radioiodine is contraindicated in thyroid eye disease, doctor. That will worsen her eye disease and also that will cancel our GMC license. Answer is E. Total thyroidectomy is the best option once the eye disease sets in. Okay. Total thyroidectomy is the best option. Subtotal, some people do, but the best option is always going to be your total thyroidectomy. Next question. 34-year-old woman with a long history of type 1 diabetes, microalbuminuria, diabetic eye disease presents for review. She has been amenorrheic for 12 months. Recent home pregnancy test has been negative. She is a 1-year-old child, but had a postpartum hemorrhage just after birth. Over the past few months, she has also been increasingly tired, as noticed thinning of her pubic and axillary hair. She's slim, pale, with a small breast and thin or largely absent pubic and axillary hair. Rarely morning cortisol, FSH, LSH, all are low. Thyroid stimulating hormone level is also low. MRI of pituitary reveals an empty cell. Yes, steroid also you can give for thyroid eye disease. Yes. What is it? Postpartum, all the pituitary hormones are low. What is the diagnosis? Only diagnosis is D. Sheehan syndrome. We have seen already. Okay. 23-year-old woman is admitted to the emergency department from her office after having suffered a syncopal attack. On questioning, she admits she's felt very tired over the past few months, having intermittent abdominal pain, being dizzy on a number of occasions. See, everything matters. Abdominal pain, dizzy, she's slim, she's tanned, her BP is dropping, her potassium is high, free T3 is slightly low, TSH is normal. What is the diagnosis, doctors? So many questions we had worked here on the same aspect. What is a syncopal attack? Syncopal attack, what their meaning is nothing other than orthostatic hypotension, which she's having. Somebody with orthostatic hypotension, with high potassium, low BP, nausea, vomiting, abdominal pain. What is the diagnosis? You guys don't need to think. So many questions we are working on this. What is it? Addison's. What is Addison's called? Primary adrenal failure or primary adrenal insufficiency. Sorry. Just 54-year-old pub owner is now referred to GP for endocrine assessment. This gentleman is obese with a body mass index of around 32 kilogram, and he also has hypertension. This is poorly controlled by atenolol and benroflumethiazide. A fasting blood glucose test reveal 9.2. He has Cushingoid and with a BMI of 32. It's already mentioned. You order a 24-hour urinary UFC, slightly above the normal range. Overnight DST is 30. What fits the best diagnosis? Is UFC is just slightly above the normal range. DST suppresses. He has Cushingoid feature. Blood glucose fasting is high. He's taking atenolol, bentroflumethiazide for hypertension. He's obese. He's a pub owner. The answer is pseudo Cushing's because they will justify telling he's a pub owner. I will tell you one thing. I know people who owns pub. Around 3 to 4 people I know in UK I'm talking about who came from India, Pakistan and established and they're owning pubs there. And among the 3-4 people, 2 people are teetotalers. They don't touch alcohol at all in their entire life. They never touch alcohol. They own pub. And other 2 people are occasional drinkers. They touch only once in a year or 2. Don't know what kind of stereotypic questions these people are taking. 48-year-old man presents for a routine checkup. He has a history of obesity and impaired fasting glucose. Routine blood shows triglyceride concentration is 6 millimole. With all the other things are normal. So what is happening here? Triglyceride is high. Impaired fasting glucose and obesity. Lot of things can actually increase the triglycerides, right? One of the things is obesity can increase. Impaired fasting glucose and diabetes can increase. Alcohol can increase. What they're asking. Is it due to secondary dyslipidemia? Is it due to beta lipoproteinemia? Familial hypertriglyceridemia? Familial heterozygous hypercholesterolemia? Pre-beta lipoproteinemia? What is the answer? The answer is C. It's called familial hypertriglyceridemia. Also, other causes of raised triglycerides, obesity, diabetes mellitus, alcohol. Don't forget, okay? All these things can rise up. 24-year-old man with a learning disability presents for review. He complains of sudden deterioration of vision in his left eye. Past history notes DVT. He appears tall, slim, and has morphonoid feature. He has markedly elevated homocysteine. Somebody with a learning deficiency, high homocysteine with morphonoid feature, also has DVT. DVT is typically due to homocysteine. Homocysteine is a pro-thrombogenic hormone. Okay, pro-hormogenic one. So it can cause DVT, it can cause myocardial infarction, everything, including your pulmonary embolism. It also has learning disability, could be due to homocysteinuria. So what is this? Due to which enzyme defect is responsible for this? So you are here dealing with homocysteinuria. Am I right? Homocysteinuria, there will be lens dislocation. What lens dislocation? I told all of you to remember like this. Urine goes down, so downward dislocation. Name urine is there, urine goes down, so it's a downward dislocation. They are asking which enzyme is deficient here. Is it A, B, C, D, or E? All of you should be knowing this. Which enzyme is deficient in homocysteinuria? Come on. The answer to this question is E. It's cystathione beta synthase. Cystathione beta synthase is responsible for homocysteinuria. A 54-year-old man with long-standing type 2 diabetes is presenting for the review. He has a history of hypertension and smoking. His recent HbA1c is 8.9. He wore deck shoes without socks on a recent holiday in Spain. One day, he noticed a large ulcer over his big toe. On examination, there is obvious loss of sensation. Okay, ulcer elicits no pain. His foot appears warm. There is some toe clawing. Toe clawing is what? He is developing some Charcot joint. They are asking what is the underlying etiology of an ulcer in a diabetic patient. That's it. All the rest of the things are story. He went to Spain. He is on a holiday. He wore this shoe. Nothing. So what is the reason for a diabetic ulceration? It's a simple trauma. Is it an arterial ulcer? Is it a neuropathic ulcer? Is it a vasculitic ulcer? Is it a Charcot arthropathy? Neuropathy is the most common thing. Okay. Neuropathy is the most common thing. The moment they lose the sensation, they may stamp on even the sharp objects. They won't feel any pain. That is the danger. So we advise all the people who are diabetic. If you want to avoid amputation, please wear good footwear, proper footwear. Okay. Now, you are asked by the psychiatrist to review a 42-year-old woman who is having a long-standing bipolar disorder and diabetes mellitus. She's taking lithium, metformin, and glycoside. During recent inpatient stay, she appears to be drinking vast amount of water and getting up many times in night to urinate. Her sodium is high, urea is 11, high, fasting plasma glucose and calciums are normal, and serum osmolality is above 300 without increasing urinary osmolality. What is the diagnosis? Again, a repeat concept. None of you should hesitate to give an answer to me. What is the diagnosis? Is it a cranial, nephrogenic, psychogenic, glycosuria, or SAADH? What is the answer? She's taking lithium. Answer is B, nephrogenic diabetes insipidus. Now, an 18-year-old woman presents with 2 months history of vague ill health, dizziness, abdominal pain. She has abnormal skin pigmentation with low cortisol. Which of the following investigation demonstrates the woman has Addison's disease? Which says Addison's disease? High cortisol after short synactin test and low ACTH. High early morning cortisol, low ACTH, and positive anti-21 hydroxylase antibody. Low 24-hour urinary cortisol excretion. Positive overnight dexamethasone suppression test. Low Yes. There is some disconnection in the internet. Again, like I said, they're doing some test. I hope all of you can hear me now, right? I hope all of you guys can hear me. Are you all hearing me? Are you all seeing the screen now? Is the screen visible to you all now? Yes, that's perfect. Now tell me what on the screen is telling you Addison's disease is positive. Which test is telling you that Addison's disease is positive? A, B, C, E, which says a positivity for Addison's? Some say E, some say A. The answer is E. Addison's disease will show low cortisol after a short synactin test. What is happening in Addison's disease? Synactin is what? ACTH. You give ACTH, will the adrenal gland produce cortisol? No, it won't produce cortisol. Why? There is a primary adrenal failure and ACTH will be high because there is no negative feedback. Pituitary will keep secreting a lot of ACTH and there will be also positive anti-21 hydroxylase antibodies. All of you are clear? This is the findings in Addison's disease. 18-year-old. Okay, the question is here. Which of the following should be given to manage adrenal crisis? That's what they are asking. In a case of adrenal crisis, what do you give? IV glucose, IV hydrocortisone and hypertonic saline, oral mineralocorticoid and IV insulin dextrose, IV saline and hydrocortisone, or IV dextrose 3% and hydrocortisone. We had discussed a similar question, so you guys need to give me an answer straight away. What is the answer here? What is the answer here? No, it's not hypertonic saline. How you will give a hypertonic saline? Hypertonic saline, where you will give? No, definitely not oral mineralocorticoids. And how you will give IV insulin and do dextrose in adrenal crisis? The answer to this is D, IV saline and hydrocortisone. This is the answer. We have seen a similar question. Okay, you don't tonic saline. 39-year-old man with uncontrolled hypertension found to have potassium concentration of 2.8, low potassium, high BP, that is resistant. After supplementing potassium, reveal a high, a suppressed renin and high aldosterone. What is the diagnosis? What is the diagnosis? Low potassium, high blood pressure, low renin, high aldosterone. What is the diagnosis? Yes, it's a Cons-like picture. So what you will do here? Next thing, what you will do here? The answer is saline suppression test. Okay. The answer is your saline suppression test, because already renin aldosterone has been taken. We can go for a saline suppression test here. Next question. How many hours do we have left, sir? Sir, we have around at least I will require another 2.5 hours, 2 hours at least. Okay, because we have watched to finish the lecture. That's the reason I am sitting with you, because I want continuity. Otherwise, with the type of laryngitis and symptoms which I am having, I thought of taking a break today and continuing the lecture next week. But I decided we all will lose the continuity. So we'll sit here today. I came. 52-year-old woman with a primary hypothyroidism is being treated with thyroxine replacement, the dose of which is titrated against the result of biochemical test. 5 days after the increased dose, her values are FT328, TSH 14, FT428 and TSH 14. High TSH and high, slightly higher thyronin. What is the next step? You are just increasing the dose and you are finding it increasing. A decrease, you will decrease, you will further increase, or you won't change, or you will question the patient's complaints, or replace thyroxine with triiodothyronine. What you will do? No problem, doctor. You are welcome. The answer is no change. Within how many days? Within 5 days. Somebody coming and you are taking a report within 5 days. Is it going to help anything? Give at least 2 weeks, 1 month time. Clearly mentioning 5 days. What do you do? Nothing. No change of dose at this time. 20-year-old woman presents with anxiety and weight loss with increased appetite. Blood shows pre-thyroid hormone levels of 44 and TSH low. Which of the following finding would suggest Graves' disease? Let's see what the options. High ESR, high T3 and normal TSH receptor antibodies, low thyroid uptake scan in technetium 99, nodular thyroid visible on ultrasound scan. Who is going to give an answer to this? Which of the following says it's a Graves' disease? Very common question. You don't need to think a lot to answer this one question. The answer is obviously C. Graves' disease is associated with TSH receptor antibodies. 35-year-old woman had a febrile infection associated with painful swelling in her neck, also palpitation and anxiety. Okay, thyroid function test reveal thyroid hormones of 50, TSH is less, ESR is raised. So someone post a viral infection, post a febrile infection, has a hyperthyroid picture. What is it called? Yesterday we had discussed. What is it called? Post-thyroid, post-viral fever. Yes. What you will do? You will give carbimazole or you will give propylthiouracil. You will just give propranolol or NSAIDs, common celltroxin, radioactive iodine treatment. All you need to do is symptomatically manage. Propranolol also you're giving because she's having palpitation and anxiety for symptomatic relief. But otherwise, if there are no symptoms, NSAIDs are more than suffice. Okay. 23-year-old woman has been referred by her GP for admission because she has been complaining of frequent episodes of sweating, palpitation, and low blood glucose. Her brother is a type 1 diabetic. Blood test shows low glucose, high insulin, low C-peptide. What is the diagnosis? Before turning to the options, high insulin, low C-peptide, low glucose. Quickly, this is your good old factitious hypoglycemia due to external insulin administration. Yes. 28-year-old woman with well-managed type 1 diabetes monitored for other autoimmune disease. I hope all of you know type 1 diabetes is associated with a myriad of autoimmune disorders. But she is euthyroid, but found to have positive TPO. She is euthyroid. Recently, she found she's 6 weeks pregnant and is an unplanned pregnancy. She's concerned about the implication of the TPO antibodies. Okay. What are the implications of TPO antibodies? That's what they are asking. Somebody has a maternal, somebody is pregnant, is coming and asking, oh, doctor, the report says I have TPO antibodies. What could happen to me? What are the consequences? Higher risk of abortion, increased risk of neonatal hypothyroidism, increased risk of PIH, macrosomia, transient neonatal thyrotoxicosis. What is the risk? Logically think and answer me. Some of the questions you don't need to break your head so much. All you need is some logical thinking. The answer is higher risk of spontaneous abortions. Okay. TPO antibody can cause neonatal hypothyroidism, but it's very rare. But the highest risk is for spontaneous abortions. Highest risk is for spontaneous abortions. Okay. It won't cause neonatal thyrotoxicosis. TPO itself associated with hypothyroidism, not hyperthyroidism. So how is going to cause neonatal thyrotoxicosis? Macrosomia is due to fetal hypoglycemia. 54-year-old man presents with GP, stating that he had met several people recently he had not seen in years, who mentioned his appearance has changed a lot. He noticed increase in shoe size, his enlarged hands, feet, macroglycemia, you suspect acromegaly. What is the appropriate investigation to confirm the diagnosis of acromegaly? After screening, they're asking about confirmation of the diagnosis of acromegaly. What is the diagnosis? I won't open the options. I want all the people who are listening to the lecture to type it. Come on. What is the investigation to confirm the diagnosis? What is the investigation to confirm the diagnosis of acromegaly? Clearly, they gave the diagnosis acromegaly. Enlarged hands, enlarged feet, macroglycia. IGF-1 is raised. Answer is E, OGTT measurement with growth hormone measurement. Next question. 11-week pregnant lady is coming. She's presenting with hyperemesis gravidarum. TFTR found, thyroid hormone elevated, TSH is low. She does not have a goiter. Thyroid antibodies are negative. How do you manage somebody with a hyperemesis gravidarum? So hyperemesis gravidarum is due to what are the hormones you know. If you're interested in OG, you can read the role with beta HCG. So what do you do for her? She's having increased thyroid hormone. What will you do? You give a radioiodine, you give immediate surgical referral, you give carbimazole, you give propylthiouracil, or you will just wait and observe. What you will do in your clinic? The answer is E, observation. Just now I said this hyperemesis gravidarum is due to increased beta HCG. This itself can alter thyroid function. So the only thing you have to do is wait for her symptoms to settle down. So, like the question says, what it says, a patient, she's having hypothyroid, hyperemesis gravidarum with hyperthyroidism. TSH is going low, no goiter, no antibody, no symptoms. What I said, hyperemesis gravidarum is due to increased beta HCG. This increased beta HCG alter the thyroid hormone by increasing T3 and T4 levels. So what you do, you have to observe and wait. You don't treat the patient at this moment. All right. So it's a practical tip. Any patient with this hyperemesis gravidarum coming to you, don't be in a knee-jerk reaction. Treat the patient at all. Okay. Next. 34-year-old woman presents with 4-month history of anorexia and weight loss. And there is excess pigmentation and dizziness on standing. Family history of autoimmune hypothyroidism. An examination revealed postural hypotension, skin discoloration, low sodium, high potassium. What is the diagnosis? Quickly, because so many times we have seen the presence. Addison's? Yes, it's Addison's. The diagnosis is you have to do a Schwarzenegger test. Right? We have to do a Schwarzenegger test. Next question. 72-year-old man with a long history of COPD. He is admitted now with a pneumonia. Prior to admission, he is increasingly confused. On examination, this gentleman is drowsy and he is having a blood pressure of around 142/75 and was clinically euvolemic. There is a pneumonia going on. Sodium alone is low. Everything else is fine. What do you think is happening? Euvolemia, normal sodium, hospitalized patient. What you will think, doctors, just to put your shoes in a shoes of a medical registrar. You are working in NHS ITU and SO black guy is calling you. Hi, sir, I have a case here. Sodium levels are dropping, but patient is fine. His BP is okay. His pulse is fine. He's not comatose. What do you will think? Obviously. What is the likely cause? The answer is E, SIADH. You don't need any much theory to answer this. Within the first 4 lines, you should be knowing this is SIADH. If you are approaching MCQs in this level, you will never go wrong. Trust me, you will never go wrong. 45-year-old woman who underwent hysterectomy. She has a history of hypertension, headache, and panic attacks. She's taking Ramipril preoperatively, but the blood pressure is of 150/85. Renal function, calcium concentration, everything is normal. She has LVH. During operation, surgeon attempts to mobilize her. Blood pressure suddenly rises to 210 and she suffers an acute MI. What is the most likely cause of her intraoperative hypertension and MI? See the case once again. Okay, somebody is undergoing hysterectomy who is a known hypertensive patient. Her BP is 150, but her renal function, everything is normal. While the surgeon operates, suddenly her BP shoots to 210. Okay, her pulse is also going to 130 and she suffers an acute MI. What do you think is happening in this lady? Is it an essential hypertension? Or is it an occult coronary artery disease? Or is it MEN1? Or is it renal artery stenosis? Or is it undiagnosed pheochromocytoma? The answer is very good. It's undiagnosed pheochromocytoma. Okay. The good old anesthetist would have tried attempting putting some beta blockers. It would have flared up. 21-year-old man with morphinoid appearance is referred by GP for review. He has been suffering from acute headaches, panic attacks. He is unable to continue his coursework. Examination, BP is high. Number of neuromas, urinary catecholamines are raised. So what is the diagnosis? Morphine, neuroma, increased catecholamine, very few. What is this? No need to think a lot. This is meant to be. How many cases we came across? This is meant to be. Next question. The question is straightforward written below. Which of the following HLA subtypes is most strongly associated with autoimmune thyroid disease and type 1 diabetes? You should know some genetics to answer the question. Okay, which HLA is associated with autoimmune thyroidism, hypothyroidism, and type 1 diabetes? B47, B27, A28, DR7, DR3. Which? Fantastic. You all know this. HLA DR3 is associated with autoimmune hypothyroidism and as well as type 1 diabetes mellitus. Okay. 74-year-old man presents to emergency department with abnormal chest X-ray revealing a right hilar mass. He is noted to have markedly raised corrected calcium. Apart from that, raised levels of urea and dehydration, his renal function is normal. Okay, normocytic normochromic anemia is seen. His phosphate vitamin D are normal, PTH is low. Which of the following is reason for hypercalcemia? So increased calcium in a patient with squamous cell carcinoma. I'm sorry, just this, they said right hilar mass. Maybe in a right hilar mass. What do you think? We just told this PTH is normal, right? PTH is low rather, but vitamin D and phosphate are normal. This is primary, secondary, tertiary, pseudo, or raised PTHRP, parathyroid hormone related protein is called PTH, PTHRP. The answer is E. Is this due to raised PTHRP? All of you are clear? Good. 19-year-old student nurse. Be careful, nurse we are dealing with. Following a third collapse in recent months, she is noted to have a blood sugar of 0.9. Finger prick testing. Responded well to IV glucose. C-peptide is 20, that is low. Insulin is more. What is the diagnosis? But PTH is low, sir. In last question, somebody is asking doubt. Yes, this is due to PTHRP, not due to PTH. PTHRP is a hormone secreted by the tumor that is in the patient's lung. Okay, go back here. No, you shouldn't have the doubt. PTHRP is due to a tumor that is secreted from the squamous cell carcinoma. Okay, that is not normally secreted. See this question. What is this? How many times we will work out the same question? But these people are doing Q bank by putting the same concept again without exploring different concept. What is the answer here? This is nothing other than your self-administration of any short-acting insulin. 35-year-old woman visits pediatric diabetes clinic with a 2-year-old son who is recently developed type 1 diabetes. He has an identical twin brother. What advice would you give regarding twins' future risk? Someone with identical twins having one twin is having type 1 diabetes. Does he have 100% chance? Or you will give a trial of low dose insulin, or GAD antibodies are not predictive, or he has 50% chance, or IA2 antibodies are in the unaffected child are not predictive. What is the answer here? Okay. Any other answer? Any other answer? Anyone? Anyone more? Okay, the answer is D. Okay. Twins are affected. There is obviously there is a 50% future risk in type 1 diabetes. You are reviewing a 45-year-old man with type 2 diabetes. Okay. What they are asking is she is going to start it on SGLT2 inhibitor. They are asking which of the following is correct regarding SGLT2 inhibitor therapy. It acts by reducing hepatic glucose output. It primarily acts by reducing peripheral insulin resistance. It is associated with slightly increased BP. Is it useful in type 1 diabetes? It is associated with reduced cardiovascular risk. What is the answer? A, B, C, D, or E? Quickly, guys, what is the answer? Is it A, B, C, D, or E? We have already discussed. The answer is E. It reduces the cardiovascular risk. No, you don't give here. Don't increase blood pressure. Doesn't decrease peripheral insulin resistance. This is done by metformin. Then this 74-year-old man admitted in the ED in an acute confusional state. Is clinically euvolemic, has a chest X-ray looking with a suspicious looking mass. Sodium is low. Osmolality is okay. SIADH is suspected. Okay, they give the diagnosis of SIADH. Which of the following biochemical finding will support the diagnosis of SIADH? Cortisol high, or urine osmolality of 380, or urine sodium low, fractioned excretion of sodium 0.5%, serum urea concentration of 2.1. What do you find in SIADH? What is the criteria for SIADH? We had discussed yesterday, right? Now you have to give me the answer. The answer is B. Urine osmolality will be higher in case of an SIADH. Okay, this is the essential criteria for SIADH. Now, following head injury, 24-year-old patient developed polyuria and cranial diabetes insipidus is suspected. So he is put on water deprivation test. Which one of the following responses will be diagnosis of cranial diabetes insipidus? Plasma osmolality will rise after water deprivation, or they will be failed to concentrate urine after water deprivation and achieved following administration of desmopressin, or failed to concentrate with water deprivation and as well as desmopressin, or failed to concentrate the urine osmolality, or weight loss of 2% during investigation. What is the answer? I'm talking about cranial diabetes insipidus. Think and answer. We are talking about cranial diabetes insipidus. What is the answer? We are talking about cranial diabetes insipidus. Read the options again and give me the appropriate answer, everyone. The answer is B. What happens? That's the reason I underlined this also, desmopressin. You give desmopressin, it will be improved. What happened? Some injury, some defect in the pituitary, posterior pituitary. So arginine vasopressin is not coming. So you give the synthetic form, that is a desmopressin. Patient will be all right. What is a big deal in getting confused in this? 49-year-old woman presents with complaining of polydipsia, fatigue, and weight loss. She has been treated medically for prolactinoma. You are suspecting MEN1. So what are the other underlying conditions in MEN1? MTC will be there, or hyperparathyroidism, pancreatic islet tumor, pituitary adenoma, or pheochromocytoma. What else you will find in MEN1, doctors? Come on, rapidly tell me. What other finding you will get in a MEN1? Yesterday, I had thought exclusively. No, please. You don't find medullary thyroid carcinoma in MEN1. I had stopped and thought also about MEN1. The answer is hyperparathyroidism is the most common in MEN1. Okay. Hyperparathyroidism is the most common. Pancreatic islet tumors, yes, it is there, but comparatively between these two, the most common is there. Definitely not E and definitely not A. These two can be seen. Among this, the most common, if they asked, what is the most common, is increased parathyroidism. Then followed by your pancreatic tumor or any gastric tumor. Now, they are given a history. What they are asking is, which of the following findings will be consistent with Graves' disease? These are all stored. Raised acidosis, decreased PaO2, increased PaCO2, decreased PaCO2, or decreased pH. What they are asking, what is the ABG abnormality in Graves How many of you know what is the ABG abnormality in the Graves? This is what exactly they are trying to ask you. What is the ABG? The ABG abnormality in the Graves disease. Anybody? Any random guess is fine. What is the ABG abnormality in the Graves? A. Then the answer is D. Okay. The answer is D. Why is because hypothyroid patients have low resting arterial CO carbon dioxide tension. So tidal volume can be significantly higher. This can lead to decreased PaCO2 because of low tension in the arterial blood. Okay, so the answer is D. This is the ABG abnormality. I'm not going to go in depth and teach anything, but remember, decreased PaCO2 is the most common ABG abnormality in Graves because the arterial CO2 tension is low. Okay, it's low. 28-year-old woman attends diabetes clinic with her 2 children. This is a third pregnancy, and this time she has been diagnosed with gestational diabetes mellitus. Her mealtime portion sizes are erratic. Recent fasting plasma glucose levels has been on the range of 5 to 6. She's taking twice daily mixed insulin. Later evening, she collapsed while shopping. It's brought to the ED with a blood glucose of 2.4. What is the management? A pregnant lady with gestational diabetes mellitus taking insulin collapses. What you will do? The options are there. I don't know why. The slide. The thing is, when that something happens, you can change to basal bolus regimen. I'll tell you here, rather I'll explain you here. In anyone going on a hypoglycemia, on an insulin, in UK, there are 2 things you will do. One, first, refer them for Daphne program. Second, change the regimen. What regimen you change? You change to basal bolus. Basal bolus regimen. Next question, 75-year-old woman has type 2 diabetes for the last 15 years, admitted for cataract surgery. All of you know, I believe, diabetic cataract. She's taking metformin 500 milligram twice daily, plain insulin 10 units at night, ramipril 2.5, ventroflumethiazide 2.5. She drinks a glass of whiskey to sleep herself at night. Her potassium is fine, sodium is low, creatinine is elevated. Liver function tests were normal, pH is 7.3, bicarbonate is 17, lactate is 3.5. Which of the following is most detrimental in these circumstances should be stopped? She is having cataract surgery, she's taking metformin, she's taking insulin. Now she is having reduced sodium, raised creatinine with lactate of 3.5, bicarbonate 17, and pH of low 7.3. What drug will stop? Ramipril, metformin, insulin, alcohol, ventroflumethiazide. It's metformin because metformin used to bring lactic acidosis. But remember, that is very rare. It's not obvious and not common. 30-year-old woman is evaluated in the endocrinology clinic because of her increased urine output. She weighs 60 kg and has 24-hour urine output of 3,500 ml. The basal urine osmolality is 210. So they are putting her on fluid deprivation test. Urine osmolality after fluid deprivation test is 510. Subsequent injection with DDVAP did not result in any further increase in urine osmolality. What is the diagnosis? Again, same back to diabetes insipidus. None of you should make any issues. So when a desmopressin is not helping, desmopressin is not helping here. Normal, primary polydipsia, SADH, pituitary or nephrogenic delay. Anybody? The answer is primary polydipsia. Okay. The answer is primary polydipsia. Okay. Why it's not a cranial DI is see the urine output here and as well as see the urine osmolality. Basal urine osmolality is 210. You won't have a basal urinary osmolality of 210 in a nephrogenic diabetes insipidus. See and go back to the slide which I showed you yesterday. And also desmopressin won't be effective. Desmopressin won't be effective in two conditions, psychogenic polydipsia and as well as in your nephrogenic diabetes. Sorry, in your cranial diabetes. All right. In nephrogenic diabetes, the desmopressin supplement, desmopressin treatment will definitely upper osmolality. So why it is not cranial diabetes mellitus? She is having a basal urinary osmolality of 210, which is not significantly telling that she is having a cranial diabetes insipidus. So the answer is B. A little tricky question. Okay, little tricky question. Okay, little tricky question. 31-year-old lady was recently diagnosed with insulinoma. She tells you mother too had a perforated duodenal ulcer due to too much acid. Maternal aunt has a pituitary tumor. What is the diagnosis here? What is the diagnosis here? Again, pituitary. Then what? Pancreatic. Then gastric. Men 1 or men 2? Don't mistake again. Men 1 or men 2? Men 2A. This is men's syndrome. They are asking what else you will find there. Along with this, along with pituitary, along with pancreatic tumor, what else you will find? You will find Hirschsprung disease or pheochromocytoma, MTC, parathyroid hyperplasia, mucosal neuroma. What else you will find, doctors? Parathyroid hyperplasia, just now we have seen. Most common in men 1. It's not men 2. It's not men 2. Okay? It's not meant to. A 35-year-old HIV positive man is evaluated for weight loss and weakness. He is known to be having disseminated tuberculosis. On examination, he is hypotensive, hyperpigmented, and the mucosa and elbow and skin creases. Which of the following likely to be found in this condition? What is the diagnosis here first? Somebody with the HIV and a disseminated tuberculosis is having hypotension and increased pigmentation. What is it? It's an adrenal insufficiency, but it is not primary. It could be secondary due to tuberculosis. Increased sodium you will find, or increased chloride you will find, increased potassium bicarbonate, or decreased calcium. Quickly, what is it? What you will find? Obviously, the only thing you will find is increased potassium in this patient. 60-year-old man is referred to the endocrine clinic. He has noted an increased shoe size. He sweats a lot, snores at night, increased glucose. What is this? Acromegaly. What is the best test to confirm the diagnosis of acromegaly? Without seeing the options, quickly, what is the best test to confirm the diagnosis of acromegaly? We had worked out enormous amount of questions. Now we should be fast. What is the best test to confirm the diagnosis of acromegaly? Confirm the diagnosis of acromegaly is OGTT with growth hormone measurement, not IGF-1. IGF-1 is for screening. 26-year-old woman attends GP complaining of feeling tired all the time. She described 4 kg of unintentional weight loss. Her mother is having autoimmune hypothyroidism. Maternal uncle is having type 1 diabetes. She feels dizzy. Which of the following clinical signs would GP be most likely to find in diagnosis of adrenal failure? So what is happening? Somebody is having a myriad of autoimmune syndromes. Hypothyroidism is there. Type 1 diabetes is there. Addison's is there. So what clinical signs GP is waiting? Buccal ulceration, diminished body hair, postural hypotension, pallor, or optic atrophy. Which sign will significantly give a clue he is having Addison's? The answer is D, postural hypotension. 30-year-old woman presents to GP with history of amenorrhea and galactorrhea. She is keen to become pregnant, but has been trying to conceive for 9 months without success. TSH is 2.6, T is 16.7, BMI is 23. No evidence of hirsutism or acne. What is the diagnosis? What is the reason for the symptoms? Anybody? Just make a wild guess. What is the reason for her symptoms? What is the reason? Prolactinoma. Okay. What says she has prolactinoma? Yes. Yes, amenorrhea and galactorrhea. See the options. Drug, she is on asthma, hypothyroidism, hyperthyroidism, PCOS, or pituitary microadenoma. The answer is E, pituitary microadenoma. Yes, because she has full-blown galactorrhea. 67-year-old man presents to ED with deteriorating vision in the right eye. In the past 24 hours, he is having a type 2 diabetes, takes metformin, glycoside. Also, he is taking medication for hypertension and hypercholesterolemia. On examination, he has finger counting only. Okay, and 6/12 on the left eye. BP is high, pulse is high. Remainder of the examination is unremarkable. Fundoscopy revealed segmental flame-shaped hemorrhage limited to the lower outer quadrant. Rare cotton wool spots are seen with normal optic disc. What is the most likely cause? Just think what it could be in a diabetic patient. Deteriorating vision. He takes metformin, he takes glycoside, he has hypertension, myriad. What could be the cause? It's a background retinopathy, branch retinal vein occlusion, branch retinal artery occlusion, hypertensive retinopathy, proliferative retinopathy. The answer is branch retinal vein occlusion. Okay, you can listen to our optal lecture where I had explained what they clearly said. See, this is the fourth quadrant. Okay, there are flame-shaped hemorrhage only to the lower outer quadrant alone affected. When only one particular lower outer quadrant is affected, rest of the quadrants are fine. You have to think in terms of branch retinal vein occlusion. I had shown this with picture in our ophthalmology lecture. We use actual fundoscopy picture and show all this. Okay. This one question, and after this, I will give a 5 minutes, 7 minutes break. Then we will continue. You review a 51-year-old man on the cardiology ward. He is recovering from an inferior MI. Okay. And is about to be discharged. A fasting plasma glucose has confirmed he is type 2 diabetes. You elect to start metformin. His creatinine is 102. He has remained stable. So what you should warn him about metformin? So a post-MI patient, you are going to start the patient on metformin. What you will warn him about the metformin? You should stop if creatinine rises 110. You should stop if angiography is planned. You should stop if symptoms of IBS are started. It may cause hypoglycemia. It increases risk of myopathy in conjunction with statins. What is the right answer? You don't need a lot of time to think what metformin does. The answer to this question is B. Metformin is a radiosensitizer. So whenever contrast agents are given, the radio contrast are given, metformin sensitizes it further, leading to increased renal injury. You need not stop for slight creatinine rise. You need not stop for IBS-like symptoms. It cannot cause hypoglycemia. Don't increase myopathy. Right? So that is the answer. Okay. What we do is I need a 5 to 7 minutes break to catch up with my voice. We will be back in 5 to 7 minutes and we will start working our MCQs as it is. Okay, just give me 5 to 7 minutes break. I'll be back. Yeah, hello doctors, I am back. How many of you are here? We will start again now. How many of you guys are here? All of you are here. Can we start? Yes, yes. Thank you. Let's begin. Okay. Now, the next question. 74-year-old man with a history of ischemic heart disease. The history of ischemic heart disease is treated with ramipril, amiodarone, furosemide, pravastatin, warfarin. Everything has been put. Is for 2 anterior MI over the past 10 years. Over the past 2 months, he has lost around 6 kg weight and he is hungry all the time and has diarrhea. Over the past 48 hours, he developed severe palpitation. On examination in the ED, his BP is 105, his pulse is high, he is in AFib. There are bilateral crackles signifying heart failure, bilateral pedal edema, again heart failure, affecting both the lower limbs. There is a smooth goiter and TSH is low and thyroid autoantibodies are positive and a thyroid isotope scan shows diffuse uptake. Which of the following is the most appropriate initial way to manage amiodarone-induced thyrotoxicosis? They themselves gave the diagnosis. This is AIT, amiodarone-induced thyroid storm. So what you will do first? Lugol, iodine, prednisolone, propyl thiouracil, radioiodine or surgery. What is the next thing you will do in your hospital, doctors? Come on, I request to all of you to be faster now because we have seen so many questions. There is nothing new is coming here, right? We are not dealing with something new. The answer is first propyl thiouracil. The first thing you have to give is large doses of propyl thiouracil, then you go for prednisolone. Okay. First option is thionomide to reduce conversion of active T3, T4. This has to be stopped. How many of you listened to my core concept lecture? I gave step by step how to manage a thyroid storm. Clinically, how do you manage when you get a patient with a thyroid storm? I told very clear concepts on that. Please go and listen to the lecture again. You will never make a mistake. Propyl thiouracil is what you're gonna give. Okay, propyl thiouracil. 72-year-old man discharged from hospital in the morning after presenting to the ED having collapsed with a blood glucose of 2.2. He has developed type 2 diabetes for 6 years. He also has metformin, sitagliptin, glycoside. A recent HbA1c was measured at 45. He admits up to 2 episodes of hypoglycemia and does not check his blood sugars at home. Examination of BP is 132, while 78, BMI is 28. What is the most appropriate step with respect to his diabetes management? He is collapsed. Hypoglycemia. Okay. What will you do? Will you stop glycoside or keep the medication unchanged? Stop sitagliptin, or you will start insulin, or you will stop metformin. Ideal thing to do is stop glycoside. Why? Because it is a sulfonylurea. It can cause hypoglycemia. 19-year-old professional athlete comes to endocrine clinic. She is preparing for some cross-country championship. She is training hard. She has a BMI of 18.5. She had no menstrual period for 4 months. She had significant reduction in her fat percentage. Her main complaint is fatigue and headaches. Examination revealed BP of 105/60, pulse of 60. BMI is confirmed at 18.5. Clinically, there is no evidence of hirsutism. TSH is normal. She has low gonadotrophin. What is the diagnosis? I am not going to show you options. All of you should be able to tell the diagnosis. How many questions we have been working about this again and again? Over and over, same concepts are being infused. This is a hypothalamic amenorrhea. How? Low LH, low FSH. An athlete significantly tries hard. This is a hypothalamic hypogonadism. Next question. Okay. The question is straight down. What is the most important side effect of carbimazole? about which all the patients should be counseled. What is the most important side effect of carbimazole? This scenario has come in phases. Okay, this scenario has come in phases. They had actually asked in the communication station, the doctor should go and counsel the patient who is going to take carbimazole. Which one of the following you will most likely dread about? Heart failure, agranulocytosis, osteoporosis, atrial fibrillation, acute kidney injury. Everyone chosen agranulocytosis. Yes, it is agranulocytosis. So you have to warn the patient of something like that of a sore throat or anything. I have to tell them. Class will go on. I think I'll try to wind up in an hour 15 minutes. Okay. A 19-year-old woman is referred to endocrine clinic with symptoms of thirst and polyuria. Her mother passed away several years ago. She had several operations prior, including one in her neck. Clinical examination is unremarkable. There are angiofibromas noted on the examination of the skin. The investigation shows elevated calcium, elevated parathyroid level. What is the likely diagnosis, doctor? Calcium is up, parathyroid hormone is level as up. She is having increased thirst and polyuria, which is a part of hypercalcemia. She is also having angiofibromas. What is the diagnosis? Men what? They won't ask men. They will ask men 1 or men 2A. What is it? It is men 1 or men 2A. Is it? No, it's not men 1. It's men 1. It's not men 2A. Why it's not men 2A here? Why it's not men 2A? What men 2A has, if you know, you will understand. Men 2A has pheochromocytoma as a fixed component. If you don't find that, please don't mark men 2A. Okay, how many questions we are working? We are working on quite a large number of questions on men. 26-year-old woman presents with increased hair growth on her arms, legs, and body. She describes 6-month history of weight gain in the abdominal region. She also noticed purplish striae on her abdomen. Her menstrual pattern is normal with cycle every 30 days. No family history of type 2 diabetes. No one else has the hirsutism. There is no evidence of acanthosis nigricans. BMI is 29. There is evidence of coarse black hair growth in arms, legs, chin, and upper lip. Pigmented purple striae. There is no evidence of virilization. So what is happening here? Here Cushing's features are there. They are asking investigation to establish the diagnosis. Androgen level, estrogen level, karyotype, prolactin level, or E, 24-hour urinary cortisol. Come on. Come on, guys. I want all of you to answer. Let's say answer. Yes, it's E. 24-hour urinary cortisol is the very first step we are going to do. Diagnose of Cushing syndrome. Sorry, 72-year-old man is reviewed in diabetes clinic. He is recently been admitted with cardiac failure. He is noted to have worsening serum creatinine over the past 6 months. Metformin 1 gram BD he is taking. Insulin glargine 32 units he is taking. BP is 155. His BMI is 34. His minor loss of sensation in both the feet consistent with peripheral neuropathy. Now what they are asking. Now all of you are clear. He is a diabetic. He is having cardiac failure. His serum creatinine is increasing. He is also having peripheral neuropathy. All right, note it down. Now, investigation-wise, potassium is slightly high. Creatinine is 210. Glucose levels are high. HbA1c is elevated. GFR is decreasing. So a diabetic guy with all this finding, they are asking what he will do. He will add a pioglitazone, he will add a GLP-1 analog, he will stop metformin, he will stop insulin, he will add sitagliptin. The guiding thing here is your GFR. GFR is 25. So you have to stop metformin. The metformin is not licensed below eGFR of 30 ml per minute. Okay. 25-year-old woman who is at 20th week of her first pregnancy comes to endocrine clinic. She's finding it increasingly difficult to maintain her weight, feel constantly anxious and tremulous. She has to taken to opening the windows at night in the middle of the winter in a bit to keep cool. So she is having heat intolerance. She has a history of type 1 diabetes, which is well controlled on insulin pump. An examination is BP is 105. She has a fine tremor. Abdominal palpation consistent with 20 weeks pregnancy. Although she is slim, BMI is only of 21. There is small, smooth goiter. So this is a kind of autoimmune spectrum we are encountering. All right. Are you all clear? Because why? She's a diabetic. She's having some thyroid disorder, to type 1 diabetic. So anti-thyroid antibody is positive. HbA1c is slightly okay, normal, I would say. And TSH levels are low. Ultrasound of the thyroid shows diffuse enlargement. Could be Graves. Which of the following is the appropriate way to manage a high dose carbimazole with thyroxine replacement, low dose carbimazole with achieving thyroid hormone levels to normal, upper third of the normal range, mid dose carbimazole, radioiodine, surgery. How do you approach this patient? A patient with thyroid disorder with autoimmune spectrum. How do you approach her? High dose, low dose, mid dose, radioiodine, surgery. The answer is low dose. Okay, never ever give high dose. There is nothing, not surgery now. Why you want to do surgery at Graves' disease at this point? It's not radioiodine. You give a low dose carbimazole, achieving the thyroid hormones in the upper third of normal range. That's the ideal treatment for Graves. Right? It's the ideal treatment for Graves. Don't forget this. 28-year-old woman presents to endocrine clinic for review. She had no menstrual period for the past 5 months and has lost her libido. In addition, she is particularly distressed by the fact she has a milk leakage on minimal stimulation of her breast during sexual intercourse. There's no past medical history. Her BP is 122, BMI is 22. Visual field is normal. You confirm milk leakage. Prolactin is elevated at 2000. MRA reveals 0.9 centimeter low attenuation in the pituitary. So some microadenoma is there with milk leakage. So which of the following is the most likely diagnosis? Drug induced prolactinemia, macroprolactinemia, microprolactinemia, non-functioning pituitary adenoma, or polycystic ovarian syndrome. Answer is C, microprolactinemia. We had worked out similar questions. It's simple now. Now the answer is simple. Question is simple. Which of the following hormone is responsible for hirsutism in non-classical CAH? Hirsutism is what? Hair growth, excess hair growth. Okay. So which of the following hormones is responsible for hirsutism in non-classical CAH? DHEAS. Listen, doctors, they are not asking which of the hormone is responsible for non-classical CAH. They are asking which of the hormone is responsible for hirsutism. In non-classical CAH, the answer is dihydroepiandrosterone, because you know none of the hormones will cause hair growth. Right? Straightforward. 28-year-old woman is seen in the resuscitation area of the emergency department. She's found to be collapsed at her home by the mother. She's been diagnosed with type 1 diabetes, GCS of 9/15, glucose rate 1.1 millimole. Patient does not have IV access. What is the most appropriate step? So here is a type 1 diabetic patient. She fainted, hypoglycemic attack. She doesn't have ICS. GCS is deteriorating. What he will do? Oral dextrose, intramuscular glucagon, intravenous glucose, glucose juice, intravenous glucose 5%, 50%. What he will give? No IV access. You have to immediately give IM glucagon and ask the nurse to immediately secure IV access. Okay. Why a doctor? She's almost in a coma state. 9/15. How you will give oral dextrose gel to her? She won't swallow it. 68-year-old man attended his GP on the insistence of his wife because his forefoot become increasingly swollen and misshapen, misshapen and unable when he walked. He has 20-year history of poorly controlled type 2 diabetes, complicated by retinopathy and nephropathy. with multiple daily injections of insulin. Which of the following best describe the pathology or management of his diabetic man's food condition? This gentleman has a food deformity. Diabetic guy is going on for a full-fledged food deformity, could be a charcot. They are asking what is the pathology and the management. Tight glucose control is unlikely to benefit. Condition is unrelated to trauma. It's not related to diabetic neuropathy. Plain radiography is normal. Pathology is related to exaggerated local inflammatory response to trauma of the neuropathic foot. How many of you know the pathology of a charcot joint? If you know the pathology of the charcot joint, you will be able to answer it with ease. The pathogenesis of the charcot joint. The answer is E. Charcot joint is due to over-exaggerated response to the traumopathic. Okay. Now, next question. 61-year-old patient with the type 2 diabetes for 8 years is treated with metformin 2 grams, glycoside 120 milligram. Okay. BMI is of 31. He is on ramipril for hypertension. Now they're asking which of the following statement is true. And ARB should be added to his hypertension. Good hypertensive control has less impact on macrovascular outcomes. Target blood pressure should be less than 140. Hypertension affects up to 20% of patients with type 2 diabetes mellitus. Direct renin inhibitor should be added to his hypertension renin regimen. What is the next thing you will do here? This is the patient with the type 2 diabetes mellitus. He's taking metformin glycoside and his BMI is high. He is on ramipril already. What is the right statement here? Read and answer me. A, C, anybody else? Quickly, target blood pressure should be less than 140. That's the absolutely correct answer. That's the absolutely right. 2-year-old man is here seen by the GP for an urgent review. He had type 2 diabetes for 10 years and is treated with metformin, sitagliptin, glycoside with HbA1c. He had feeling of severe aching pain and paresthesia in thigh. He has also complaints of anorexia and a 3 kg weight loss. On examination, there is a proximal muscle weakness. What is the diagnosis? A diabetic patient coming to you with severe numbness and aching and paresthesia in thighs. They will come running to your clinic with proximal muscle weakness. There is only one diagnosis for this. Pain in thigh with paresthesia. They will come running to your clinic. Oh my God, I can't sit, I can't lay down. I'm having this pain, doctor. What is the diagnosis in a diabetic? In a diabetic, what is the diagnosis, doctors? Anybody? Anybody? Neuropathy, what is the neuropathy? Now tell me, 80% of the patient fully recover from condition. Is this right? Or commencing insulin therapy is the mainstay. Recovery from this condition will occur over 1 year. This condition is more common in type 1 diabetes. Weight loss is unlikely to be related to the diagnosis. The answer is B. Okay, the answer is B. I'll tell you what is this. This is called diabetic amyotrophy. Patient will have severe pain in the thigh and paresthesia. They will come running. Once that is sets in, with the HbA1c of 10.4%, what you are going to do? You are going to put the patient on insulin because you want the patient at least to be halted at this level and prevent him entering into the worst complicated states in his life. Right? Next question. 52-year-old woman who lost 8 kg in weight referred for an opinion. With the background of type 2 diabetes mellitus, treated with metformin. What is happening here? HbA1c is 64. MCHC is on the slightly higher end of the normal range. MCV is normal. Hemoglobin is slightly low. On examination, she has angular stomatitis, well-demarcated erythematous rash in the groin, which extends to the lower limb, buttocks, and as well as perineum. What do you think is happening? Somebody with a diabetes. She is having some anemia. What are the problems here? Diabetes, anemia, angular stomatitis, plus rash in buttocks. What do you think is the diagnosis here? Then tell me what is the management. What do you think is the diagnosis here? What is the name of the rash? What is the name of the rash? Anybody? Yesterday we saw. If you don't know the diagnosis, you won't answer the next step in the management. Come on, all of you. Think and give me an answer. I'm waiting for your answer. I don't want to just like that read the slides and go like people do. I want to sit and talk, clarify your doubts. Do my best to make sure you all pass the examination. Anybody? Nobody knows the diagnosis. So what is given here? You will commence insulin treatment here. You will commence a GLP-1 analog. You will refer for lower GA endoscopy. You will measure plasma glucagons. You measure plasma somatostatin levels. The answer is D. What is this? This is a good old glucagonoma. What is the name of the rash? This rash is called necrolytic migratory erythema. This rash you will find in a diabetic patients. What are the clues? She's diabetic. Anemia is there. Rash, clearly they are telling. Demarcated erythematous rash in the groin extend all the way from buttocks to perineum. Why you would start insulin? Because a diabetes control is fine. Why you want to commence on GLP-1 analog? She lost weight. Why you will commence on that? Why you will refer for lower GA endoscopy? This is not a somatostatinoma. This is a glucagonoma. So the diagnosis is D. Okay. This is the rash. This is called necrolytic migratory erythema. Treatment, you can give 5-fluorouracil, glucose control. 68-year-old woman is referred for an opinion. She was diagnosed with type 2 diabetes 6 months ago. Now having impaired fasting glucose before that and is being treated on metformin. She reports she lost 5 kg despite not attempting to lose any weight. Unintentional weight loss. Her GP is thinking about insulin therapy because HbA1c is 8.3%. Hemoglobin is 100, MCV is 86, MCHC is 35. In examination, she has angular stomatitis, demarcated erythematous rash in her groin, extending down to buttocks. What is the diagnosis? What is the diagnosis? Just now we have seen. You don't need more than few seconds to tell. Same type of question. Diabetic, weight loss, rash, same, glucagonoma. Answer is glucagonoma. 45-year-old man with dilated cardiomyopathy with an ejection fraction of 10% takes amiodarone. He's doing well, but found to have free T4 of 34 and TSH. This is a case of amiodarone-induced thyrotoxicosis. Now they are asking which of the information given, what is the best first-line treatment for the thyrotoxicosis? You give radioiodine, you give Lugol's iodine, you give antithyroid drugs and corticosteroid, you thyroidectomy, or you discontinue amiodarone. So now the thyroiditis has been set already. So what you will do? You give antithyroid drugs and corticosteroid. That is the treatment of choice here. Amiodarone is thyrotoxicosis. Okay. This question. 41-year-old heavy smoker is referred to GP with serum sodium level of 125. He feels generally unwell and apathetic and has no seizure activity because you know hyponatremia beyond a point will cause what? Seizure. He is clinically euvolemic. Chest X-ray shows right hilar mass. Serum osmolality is 268 low. Urine sodium is high. Urine osmolality is 110. Random cortisol is normal. What is the most appropriate management? Before that, what is the diagnosis? A smoker in an X-ray confirmed right hilar mass with a low sodium level. We have worked out such questions, so no need to think a lot to give an answer. This is an SIADH. Could be due to non-small cell lung carcinoma. So what do you do? What's the first step? What is the most appropriate initial step? A, B, C, D, E, normal saline fluid restriction, desmopressin, IV glucocorticoids, perform water deprivation test. The answer is B, fluid restriction. You are called to a psychiatric unit to see a 18-year-old woman with anorexia nervosa. She has been admitted with refeeding. BMI is 13. What do you expect to see in the results of her biochemical investigation? A person with anorexia nervosa admitted for refeeding. What you will see in that? Raised LH and FSH, elevated circulating cortisol, low resting GH, increased levels of GnRH, normal estrogen level. I'm not talking about refeeding syndrome. She is admitted for refeeding syndrome, doctor. In a patient with anorexia nervosa, otherwise they are asking what you will see. Okay, absolutely yes. Elevated levels of cortisol. We have seen yesterday when we were doing the past test question bank. 62-year-old woman recently diagnosed with primary hyperparathyroidism had a serum calcium concentration of 2.9, high PTH level, low phosphate, normal creatinine, high urinary calcium excretion. System maybe an ultrasound scan reveal a right-sided parathyroid nodule. She has a history of renal stones, bone mineral density is normal. Somebody is having primary hyperparathyroidism with renal stone. Parathyroid adenectomy, long-term observation, long-term bisphosphonates, hormone replacement therapy, oral cinacalcet. Thing you're going to do is a parathyroid adenectomy, straightforward, right? 52-year. The question is here. What is the most frequent recorded side effect of hormone replacement therapy? What is the most frequent effect? Breast cancer, decreased bone mineral response density, venous thromboembolism, cholelithiasis, breast tenderness. What is the most frequent side effect? Anybody? The answer is breast tenderness. Of course, there is venous thromboembolism, pulmonary embolism, DVT, but the most frequently reported side effect is breast tenderness, hot flushes, mood changes. These are the things. And it's not your venous thromboembolism, which is most frequent. They're asking clearly, most frequently recorded. Okay, every word is important. 28-year-old man presents with erectile dysfunction, has no past medical history, not taking any medication, recreational drugs or alcohol. What is the commonest cause in this age group? Many patients may come, okay, and I tell, I'm having erectile dysfunction. I am not lasting for beyond 2-3 minutes. I'm not able to continue my erection till intercourse. What should I do, doctor? What is the commonest age group in an otherwise normal person? Alcohol, beta blockers, diabetes, psychological factor, testicular tumor. Unless proven otherwise, it's psychological factors. Okay. So you have to give something called Senate therapy. They ask you. Next question, 52-year-old woman presents with troublesome menopausal symptoms. She's having hot flushes and sleeping poorly. She wishes to commence on HRT. Wants to know the side effect and potential benefit. Which of the following should you tell about? She's at increased risk of type 2 diabetes from HRT. She's at increased risk of VTE. There is no increased risk of breast cancer. There is reduced risk of ischemic heart disease. There is no impact of fracture. What is the thing you are going to tell? This lady who wants to start on HRT. Obviously, the answer here is B, because none of them are correct. Diabetes won't occur. Of course, she will be at increased risk. Increased risk, there is impact. 45-year-old man with type 2 diabetes presents for review. He is on maximal dosage metformin, HbA1c of 7.8%. You elect to add dapagliflozin, which is the mechanism of action of dapagliflozin. Yesterday itself we have seen what is the mechanism of action. What is the mechanism of action? A, B, C, D, E. It acts on PPAR, or it delays gastric emptying, or it increases peripheral insulin sensitivity, or it acts by stimulating insulin output, or it acts by increasing glucose. Dapagliflozin is what? Sodium glucose transport, co-transport inhibitor. So it acts by increasing the renal glucose excretion. Next question. 52-year-old woman is referred by the emergency department with a Colles fracture. The second in the last 3 years. She underwent radical hysterectomy, bone densitometry confirmed osteoporosis, calcium and PTH assays are normal. Which of the following is most likely to be true concerning the underlying pathophysiology? They are asking what is the true statement regarding osteoporosis among the statements given above. She has suffered predominantly cortical bone loss. She has suffered because of cortical and trabecular bone loss. She has suffered predominantly because of trabecular bone loss. Underlying hyperparathyroidism will have contributed. Underlying hypoparathyroidism will have contributed. What is the answer? What happens in osteoporosis? The answer is C, trabecular bone loss. Osteoporosis affects trabecular bones, not the cortical bones. Okay, that's the answer. 48-year-old man has experienced weight increase of over 4 kg in the past 2 months. He also has poorly controlled blood pressure despite taking 3 oral agents. BP is around, also he is having impaired glucose tolerance. BP is around 165/92. Pulse is around 72 beats per minute and regular. BMI is 31. He has abdominal striae. What is the best investigation? So they are talking whether it could be a Cushing's. What is the best initial investigation you will do? DST, metirapone, short synactin, serum ACTH, 24-hour free urinary cortisol. Best initial investigation. Answer is E, 24-hour free urinary cortisol. 28-year-old man presents with hypertension, that is GP is finding it difficulty to manage. There are number of metabolic abnormalities found on investigation. He is concerned about the possibility of Conn's syndrome. The blood picture is of metabolic acidosis with hypokalemia, low renin and high aldosterone. We know that, Conn's syndrome. Now they are asking which is the best fits the clinical picture of Conn's. Which best fit the clinical picture? This is obviously which Conn's, Barter, Addison's, Conn's or Gittleman. Okay, see the abnormalities: metabolic acidosis, increased potassium, low renin, high aldosterone. What could be the cause? Is it Conn's, or is it Gordon, or is it Barter, Addison's, or Gittleman? What are the problems? Increased potassium. What other things we saw? Metabolic acidosis, low renin, high aldosterone. Will Gittleman have high aldosterone? Conn's is ruled out here because of increased potassium. Addison's is ruled out here because this patient is having number of metabolic abnormality. Aldosterone is high, so this is ruled out. Barter occurs mostly in the younger age group. Gittleman doesn't present like this. I already told you about Gittleman. Only diagnosis is Gordon syndrome. It's called pseudo-hypoaldosteronism. It mimics Conn's, but the difference between Conn's and this is increased potassium. Increased potassium will not be seen in Conn's. You know Conn's syndrome, hypokalemia, right? This is pseudo-hypoaldosteronism or called Gordon syndrome. 35-year-old man presents to ED with palpitation. On further questioning, he admits to progressively worsening headache, which GP has arranged an ultrasound and a urine test results in are awaiting. BP is 195. This reverts spontaneously while he is in department. He has a heartbeat of 140 and it reverts. Investigation shows narrow complex tachycardia, left adrenal mass. So obviously you are going towards a diagnosis of pheochromocytoma. How do you best initially manage in respect to pheochromocytoma and episodes of SVT? You will give metoprolol, you will give pinoxybenzamine, you will give digoxin, you will give amiodarone, or you will give verapamil. The answer is B, phenoxybenzamine. 35-year-old woman with strong family history of breast cancer visits you because she's keen to start on tamoxifen. What is the mode of action of tamoxifen? What is the mechanism of action of tamoxifen? Do I have to tell? Straight away, is it reading? Does it act on progesterone receptor as an agonist or antagonist like A and B? Or is it acts on estrogen receptor as an agonist or antagonist like C and D? Or is it a mixed estrogen receptor and a receptor antagonist and partial agonist? What is the action of tamoxifen? Excellent. The answer is E. It's a partial agonist and an antagonist at estrogen receptor. All right. The answer is E. You are asked to urgently review a 68-year-old man who is slowly enlarging hard mass on the anterior neck. Thyroid ultrasound reveals infiltration and biopsy reveals dense infiltration with fibrous material. T4 is 10 to T4, T3 is 4 low, and her TSH levels is markedly raised, consistent with hypothyroidism. Thyroid autoantibodies are negative. So what is this? There is a hypothyroidism. This is in an elderly lady, and there is a fibrous infiltration, fibrous material infiltration. Riddle's thyroiditis, thyroid carcinoma, Hashimoto thyroiditis, Graves' disease, toxic MNG. Why in lymphoma you will get fibrous material? Lymphoma, if you get an FNAC, what you should get? You will get lymphocytes. This is a Riddle's thyroiditis where you will get fibrous infiltration. It's also known as woody goiter will be there. Okay. We will just take 5 minutes break for my throat's sake. I'll just take 5 minutes break. And after 5 minutes, we will finish up the session. We have just another, hardly another 50 slides. We will be finishing. Please stay back. Just give me 5 minutes or just even give me 2 to 3 minutes. I'll be back. 5 minutes, 2 to 3 minutes. And we will finish the session in another 20 minutes. Okay. Just give me 5 minutes. I'll just have some water and come. Hello, doctors. I'm back. I gave a break, that's why no voice. Yeah, I just gave a 2 to 3 minutes break time, that's why no voice. If I keep talking, then I will have no voice further for any lecture. That's the state of my throat. I'll just quickly wind up. Don't worry, okay? Quick go through of some MCQs. You referred a 17-year-old girl who is a part of a family that avoid medical services. Her mother is concerned that her daughter is short of her age, does not commence her periods. She is below the 50th centile of her height. She appears to have excess skin around her neck and not developed secondary characters. And she has a 45X picture. This is a medical student diagnosis. 45X, what is the diagnosis? Come on here, everybody. Obviously, it's your good word. Turn us on. 74-year-old man is maintained on metformin therapy for type 2 diabetes. He is presenting to the emergency department with this acutely unwell. He is in shock, drowsy, confused. Blood test reveals decreased pH, bicarbonate is low, and lactate is high. Chest X-ray shows consolidation. Ketones are not significantly elevated. In a patient with metformin, low pH, high lactate, chest X-ray showing consolidation, normal ECG, ketones which are not significantly elevated. What do you think it's happening over here? What is the diagnosis first? What is the diagnosis? Lactic acidosis, right? So how do you treat the lactic acidosis? You give insulin, you give bicarb, you give dextrose, you give hypertonic saline, you give isotonic fluid. How many of you have treated lactic acidosis in your day-to-day practice? You will be knowing in reflex. The thing you need to do is you have to give isotonic fluid. Okay, I have to give intravenous isotonic fluid because along with the lactic acidosis, he is also having sepsis. So the best thing is to give an isotonic fluid, not bicarbonate. Isotonic fluid is the best thing you have to give in this patient. 64-year-old man with type 1 diabetes for 45 years presented for review. He has poor control. HbA1c is 75 and he takes multiple daily injections of insulin. He complains of multiple areas of skin changes in the abdomen. Okay. And on examination, he has severe lipohypertrophy. Which of the following is the cause of lipohypertrophy? Formation of anti-insulin antibodies, incorrect injection depth, concomitant use of metformin, local pressure from clothing, repeated insulin injection on the same site. What causes insulin-induced lipohypertrophy? Everyone knows the answer is E. Due to repeatedly somebody going to put insulin in the same site, it's going to cause them. 37-year-old man presents with routine pre-employment check. He is found to have triglyceride of 5.5 millimole and HDL and normal HDL and LDL cholesterol levels, BMI of 31. What is the best thing that fits the lipid abnormality? His VLDL will be elevated. Usually it will be improved by glucocorticoids, usually improved by alcohol. He has autosomal recessive mode of inheritance. He is at risk of acute pancreatitis. Which of the following is true? They are asking which of the following is true about hypertriglyceridemia. Which of the following is true about hypertriglyceridemia? The answer is A. Okay. The answer is A. Okay. The answer is A. This is autosomal dominant, so it's ruled out. Not everyone with hypertriglyceridemia are at the increased risk of acute pancreatitis. So the option E is out. It is going to be improved by alcohol? Definitely not. Alcohol will increase the triglycerides, so it's out. It is going to be improved by glucocorticoids? No. Glucocorticoids again causes insulin resistance. That insulin resistance will further flare up and lead to the development of hypertriglyceridemia. So that is also out. What is the only option? Option A is the right answer. Now, a 61-year-old non-smoking woman, no previous cardiac history, referred by GP with lipid clinic. Her total cholesterol is 8.5 millimole, LDL 5.5, HDL 2. Her BMI is around 30 kg. BMI is 30. And background history of sleep apnea. On examination, you notice skin is particularly dry. There appears to be some evidence of hair loss. Okay? There appears to be some evidence of hair loss. What is the next step in our management? Genetic testing for heterozygous hypercholesterolemia, dietary lifestyle and advice, commence high dose statin, check thyroid stimulating hormone, check fasting blood glucose. What you will do in this case? The normal clinical scenario which you get on day-to-day basis. So you should be able to tell me what you will do. The answer is D. What is happening? Dry skin, hair loss, increased cholesterol. What it says? It all says decreased thyroid hormone, hypothyroidism. So the first thing you need to do is check thyroid stimulating hormone and free T4. 17-year-old. The question is down. What is it? That's a question. They are just given a history which is of no use. Which of the is the reason for ketoacidosis? Why diabetes mellitus getting DKA? Why? What is the cause? Lipogenesis, lipolysis, gluconeogenesis, glycolysis, glycogenolysis. The answer is lipolysis. Excellent. Because insulin pushes the lipid into storage mode. When there is no insulin, lipid lies in ketone body forms. 32-year-old woman presents to the clinic with tiredness. She has 3 children and a full-time job, finding it difficult to holding it all together. Okay, no significant medical history. BP is 145, BMI is 28. Investigations are follows. T4 is low normal, T3 is okay, TSH is high. What is the likely diagnosis? Hypothyroidism, thyrotoxicosis, thyroid hormone resistance, subclinical hypothyroidism, TSH1. See the values again. TSH is 8.8, T4 is 11, T3 is 3.6. Clearly seen? The answer is yes, it's D. Subclinical hypothyroidism. What should happen when TSH is high? T4 and T3 should be reduced. Am I right? It should be reduced, but it's not reduced. It's in the borderline normal. So when you find such thing, it is obviously signifying there is a subclinical hypothyroidism. I'm sorry. 38-year-old woman presents to her GP with 6-month history of secondary amenorrhea. She also noted some galactorrhea. FSH is 2.3, low. LH is low. Estradiol is again low. Physical examination is normal. When somebody presents to you with this finding, what do you will think of? A 38-year-old lady with secondary amenorrhea, her FSH is low, LH is low, galactorrhea is there, and estradiol is low. So it could be something happening centrally, that is at the pituitary level. So what is this? Turner syndrome, PCOS, microprolactinoma, Sheehan syndrome, or hypothyroidism? Obviously, the answer is C, microprolactinoma. Next question. 42-year-old man with recurrent episodes of pancreatitis is found to have severe hypertriglyceridemia. He is seen by a lipid specialist and is diagnosed with hyperlipoproteinemia type 1B. Which of the following mutation is the reason behind that? They are asking which of the mutation in which of the gene coding for the protein. Apolipoprotein E, C2, A2, B, or LDL receptor. What is the condition? Dyslipidemia type 1B. The answer is B, apolipoprotein C2. There is a table I pasted in my core concept lecture. Please go through that. Please go through that, because right now it's not the time to teach you the full dyslipidemias. Please go through the table. The table will tremendously help you. Okay. Now, next question. A 65-year-old woman known to have chronic low back pain. She notices a severe sharp pain in the left groin after a minor fall, and she is unable to walk. She was born in Nigeria but has been living in the UK for 50 years. Left neck of femur fracture is elevation discloses serum calcium concentration of 2. Low calcium. Serum phosphate is 0.68. Low phosphate. PTH levels are high. 80. Renal function is normal. What is the diagnosis? What is happening here? IBM, some fracture, okay, increased PTH, low phosphate, and low calcium. What is the diagnosis? What is the diagnosis? Primary hyperparathyroidism, hypervitaminosis D, Paget's disease, idiopathic osteoporosis, vitamin D deficiency. The answer is vitamin D deficiency. It's a case of an osteomalacia. Why phosphate level is going to be go low? You won't get a low phosphate levels. The answer is E. It's a vitamin D deficiency. 52-year-old woman here. Known case of MEN1. Remember MEN1. Presents to endocrinologist with recent diagnosis of type 2 diabetes mellitus. She also unintentionally lost 5 kg in weight. Endocrinologist notice a rash. We have discussed this. What is the diagnosis and what is the name of the rash? We have discussed just now. Some time back we discussed necrolytic migratory erythema. I'll write again for you. Necrolytic migratory erythema. Diagnosis is your good old glucogonoma. Okay. Necrolytic migratory erythema is the answer. Next question. 23-year-old woman presents to GP after the birth of her second child. She complains of tiredness, persistent hoarseness in the voice, having problems shaking off. Although she's breastfeeding a child, she's failing to lose a pregnancy weight. TSH thyroid antibodies are negative. TSH level is 12, free T4 is 5, and no thyroid tenderness. GP notes her pulse is only 52. Post-pregnancy, somebody is having some sort of hypothyroid-like symptoms. What is the diagnosis? Hashimoto's, postpartum toxic MNG, iodine deficiency, Graves. We have seen this multiple times. Do I have to tell you? You will tell me the answer. The answer is B. This is your postpartum thyroiditis. That's the answer. 57-year-old woman presenting a feeling of shortness of breath and choking. Okay. She is feeling shortness of breath and a choking sensation, especially when she lies down. Some 4 months ago, she had been diagnosed with AFib. She started on aspirin and digoxin by her GP. On examination, GP could find an irregular nodular goiter. Blind radiography confirmed retrosternal extension. TSH levels are low and FT4 levels 33. Thyroid autoantibodies are negative. What do you conclude here? Negative thyroid autoantibodies. Okay. There is retrosternal extension of the goiter. Irregular nodular goiter. She is on atrial fibrillation, started on aspirin and digoxin. She was not given any amiodarone. No such thing is given here. Which fits the best diagnosis? Is it Hashimoto's, toxic MNG, thyroglossal cyst, follicular thyroid carcinoma, or a Graves' disease? Who said anaplastic? No, doctor. Anaplastic thyroid carcinoma is the worst thing, that rapidly improving, rapidly enlarging swelling. What is this? This is a simple toxic MNG. What they said, the name itself here, they clearly mentioned what he said. He is finding an irregular nodular goiter. That's itself a toxic MNG. No autoantibodies. No autoantibodies rules out what? Graves' disease. Because Graves' disease will have what? TSH receptor autoantibodies. Yeah? It's a toxic MNG. 62-year-old man presents with 6 months after first being diagnosed with type 2 diabetes. He's been taking metformin 2.5 grams since the day he diagnosed. BMI is 30. Despite having intentional weight loss of 7 kg, his blood glucose HbA glucose is still 9 and sorry, there is some disconnection. I'm back again. Please be here. Okay, so here we go. He's been taking metformin. His BMI is 30. Despite having weight loss, his HbA1c is still high, and also his blood glucose. He is hypertensive dyslipidemia, and he is already taking ramipril and as well as atorvastatin. Which of the following therapies would be the best choice for hyperglycemia and obesity in addition to the metformin therapy? You will give insulin degludec, glibenclamide, pioglitazone, dapagliflozin, acarbose. What are the factors you need to take in consideration? His BMI and what drugs he is already on. Now, what drug you will give here? The answer is obviously D. Dapagliflozin is the right drug you are going to give here for this gentleman in this particular situation. Okay, we have discussed this already. I think this should be the last question of the day. 23-year-old South African woman was recently started on OCP for contraceptive purpose. She comes to the dermatology clinic. She is concerned because her skin on her hands and forearms become increasingly fragile. She has a bullous rash. In addition to increased pigmentation and some hair growth on her face, on examination, her mucous membranes, there is no abnormality. What is happening? Somebody is taking OCP, then she is having a bullous rash with hair growth on face. What they are asking here? Okay, everything lab abnormality, nothing is there. Anti-nuclear antibodies were positive. ANA is positive. She notes that similar episode occurred when a few years previously when she took a specific antibiotic for urinary tract infection. What is the likely diagnosis? PC, Stevens-Johnson syndrome, 10, PCT, or systemic lupus erythematosus? The answer is B, PCT. Come back, I'll tell you why. What are the findings here? After taking rash, then she is having hair growth. Hair growth on face is one of the classical things we will find in Porphyria cutanea tarda. Our derm lectures have clearly explained all these things with pictures, patient pictures. I have told you how it looks. Okay. Second, other important thing, she is having ANA positive because many people with ANA is a non-specific test, first of all. Okay. ANA is a non-specific test. Here they are giving, she had a similar episode few years previously when she actually took an antibiotic for UTI. Many of the antibiotic can trigger PCT. Alcohol can trigger PCT. All these things points to nothing other than your porphyria cutanea tarda. I thought of taking this in derm, but this question came in your good old endocrinology. Okay. With this, I am winding up the lecture. Few things before I close. I hope all of you would have benefited by the lecture. Okay. If any of you have not joined us, you want to join us and learn and listen to us, you are more than welcome to join. Yes, Dr. Sundar, you can tell. You are more than welcome to join MedEx Expert, because here we cover a wide variety of subjects. You should listen to our core concept lecture. We cover more than anyone else. I can boldly challenge on that because of the hard work we put behind that. That is one thing. You are more than welcome to join us in the next sessions. We are going to cover all the MCQs in past test and past medicine for all the subject, every single subject we can cover. Okay, every single subject we can cover. So you guys are more than welcome. We are expecting you, and you're all welcome. Thank you so much. And also, please, whichever group you are coming from, lab group or MRCP1 group or whichever it is, please, please do one thing. Give your valuable feedback in the relevant group. Please, that will encourage us. You have a good suggestion. Based on the suggestion only we started, doctor. Now endocrine is started. Now in the future batches, we are going for neurology and other things, because the thing is availability of the mentors. Because right now I am in a phase where I've done, I'm in a break before my higher specialty training. So I am able to coordinate and do things, but other mentors are not free as I am, because they are busy consultants. And I took another break for some personal reason as well. That's why I'm able to do it. But definitely the suggestion has been taken. In the future batches, this is going to be happen. Our only aim in Mentex by Exam Expert is core concept lecture, which we will completely reinforce you all the subject with good clinical videos and updated nice guidelines and easy to remember tips. Then we will work out all the MCQs of all major QBanks. Leave one examination, we don't touch it. After this, we also want to work out all the past papers, all the last 5-year past papers. That's enough. Okay. So if someone is sitting and teaching you all the concepts, working out all the MCQs with you, and working out all the past papers with you, if still that person goes and fails, then no one can save him. I can bet on anything. With this level of in-depth thing, we will do. Okay. Please leave your feedback in the groups. Thank you, everyone. Thank you so much. Good night. Have a great day. We will see you again with more free lectures. Okay. See you. Bye bye. Okay. Yeah. Please ask. I'm here. Please ask. Please ask. Go ahead. I'm here. Tell me. No problem. Tell me. Tell me. Please ask, doctor. Go ahead. Type it. And thank you, Dr. Jodimala. Long hours of study. Clear whatever is there first in the. Okay. You want to study long hours? First thing I'll tell you, this is not some philosophy, but I will tell you. There is something called aim and plan in life. Okay. So many people will have aim. I can have aim, you can have aim. You can ask anyone, what is your aim in life? They will have aim. But planning is needed. To study long hours, you should plan. And you should be really consistent. Okay. That's the second thing I would suggest. If you want to study, like, for example, I want to study from 9 p.m. to 2 a.m. I should consistently sit on the time. Okay. I should consistently sit on the time and do that. Even sometimes, even if I get sleep, I have to do that. First, there should be a plan, there should be consistency, and definitely take 8 of coffee. And above all, I will tell one more big thing to for long hours of study. A good study partner is a big blessing. A good study partner is a big blessing. During my PACES preparation, I prepared with big time consultants from India. So it was a really blessing because we all reinforce each other. And throughout the time, I had one partner, Dr. Ibrahim. I had. We both are like brothers, like everywhere we go. Even if I tend to sleep at night without studying, he calls me and wakes up. And if he sleeps, I'll call him and tell, like, hey, what are you doing? No, don't sleep, get up. He'll be like, sir, my head is aching. My throat is no problem, you come. So you need a study partner. If you have all these things, you will stand for long hours. Okay, that answers your first question. Would there be a recording of the session so we could go it over again? And yes, you have to talk to the moderators. They will be doing, doctors, because I am not going to handle all these things. Second, some of senior doctors are saying at the end of all this hard work, you'll have no value in NHS, or you will suffer so much depression. What is your advice? Okay, NHS, a lot of people came. I'll tell you about NHS. This question I'll answer. NHS, a lot of people came alongside during our batch in NHS. There are people who left in 48 hours. A guy who did IMT, he got CCT, that is ST45 training in cardiology. He left in 48 hours, trust me. In 48 hours, he left. I just got a call. He was like, I'm leaving. Can you come? I want to say bye-bye to you. I was like, where are you leaving? What the hell you are talking, man? Idiot. You just got CCT cardiology. This is a dream branch. What the hell is wrong with you? He could not sustain. There is pressure. Okay. There is no doubt there is pressure and there is depression. It's not just in NHS, it is everywhere. You want to go to a country where there is a very least pressure and least depression and more thing. There are two places in the world. One place is Europe, another one is Australia, where the quality of life is good. But to go there, the best way to go there is having NHS experience. The reason why they prefer NHS experience is they know if someone can survive in 2 years in NHS, they can survive in any part of the world. So I would suggest have that experience for 2 years. You need not be remaining in NHS for your lifetime. Get that exposure, get that experience, have some acumen, make a good CV, try to move to Australia. For example, I'll tell about a friend of mine. Okay. You can find her in YouTube. What she did is she did her Flab 1, Flab 2. She came to UK. And while she was preparing for this, she completed her MRCP 1 and MRCP 2 as she came to UK and she did her IMT and she also did her cleared her paces there. Then she worked for 1 more year, overall 3 years. Now she straight away went to Australia. Can find her YouTube videos. A lot of people like that move. Now her life is far, far more settled. Far, far more settled. She hardly has 7 to 8 to 12 patients in her wards. So what do you think she will do in internal medicine? Not much. She went as a medical registrar. She's earning well, good life, good weather, good people, beautiful country. But at the same time, there are people who try to enter Australia through AMC 1 and 2 pathway, which is very difficult. AMC, passing AMT to AMC 2 exam is extremely difficult. Extremely difficult. So even when they went in, they have to be under supervised training. Then after that, you have to do something called BP 1, 2, 3. That is basic physician training 1, 2, and 3. Why I'm telling is I lived in Australia, in Adelaide. That's why I'm telling you. So that is a clumsy route. So people with NHS training, they easily get into that. The problem occurs with people who just trust NHS for lifelong. You ask me, if you are asking me, are you trusting UK for your lifelong career? Definitely not. But UK for me is a training ground. I go and train and I will move to somewhere else. If you have that attitude, UK is the best place to learn. And MRCP is one of the best degrees to do. But people who don't have the knowledge of this, they suffer. Another example I will tell you. Another friend I know who finished his MRCP, another girl only. They are more smarter. Finished her MRCP. She learned the German language, all the paths. Now she's working in Austria as a medical registrar. Her payment is 9 lakhs Indian money per month. Her work timing is 9 a.m. to 3 p.m. with weekend off. What else you need in life, doctor? With that much money, you are working from 9 a.m. to 3 p.m. Most people are very healthy there because less pollution. So this is the actual truth about NHS. People who believe it like US, like once we done USMLE, once you go to US, you are forever settled there. That is different. If people try to come with an attitude to UK, they are going to suffer a little. I'm being very honest because I'm not going to paint a rosy picture like some other people painting in YouTube. Oh, come to NHS, come on. UK is a great place. Finish MRCP, you will become this, that. You watch my previous videos in YouTube, I have been brutally honest. And people don't like because I'm being brutally honest. I'm not giving any false information. It's fine. At least I don't want to lie to you and spoil your future. This is the fact. Okay. Thank you so much, everyone. Good night. See you, everyone. Please do review in the groups. We will have more and more lectures like this coming. Not just this, after 3 to 4 months, I will invite some NHS consultants, some PACES examiners. You can talk to them and you can get to know them. All right. Thank you so much. You can watch in our MedExam Expert is our YouTube channel. You can find it. Okay. Thank you so much, everyone. Good night. I'll see you soon.